Testing. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera and a very good morning, everyone. Welcome to Session 1, Faculty of Medicine Research Carnival 2022, entitled A Journey of an Adolescent Cohort Study in Malaysia. My name is Dr. Nik Daliana Nik Farid. I am an Associate Professor and Public Health Medicine Specialist at the Departments of Social and Preventive Medicine, Faculty of Medicine, University of Malaya. I will be serving as your MC today. A warm welcome to Faculty of Medicine, industry partners, community representatives, postgraduate and undergraduate students, speakers, ladies and gentlemen, and participants who are joining us online. Regarding the presentation, apart from Prof. Hazrin, each speaker is given 15 minutes to present. Prof. Hazrin, you have 30 minutes. Then I will invite questions from the audience in the Q&A session at the end. We have standing microphones in front, so if you have questions, please come forward, tell us your name and affiliation, and pose your question. We only have about 5 to 10 minutes for Q&A, so I can only allow a maximum of 3 questions. For those who are present online, you may post your questions in the chat box. Ladies and gentlemen, this session on A Journey of Adolescent Cohort Study in Malaysia addresses findings from the Malaysian Health and Adolescent Longitudinal Research Study, or better known as MyHearts. MyHearts is the first adolescent cohort study in Malaysia. Over the years, this cohort study has provided us with a large number of novice facts on Malaysian adolescents' health status, which can result in effective intervention strategies to prevent chronic non-communicable diseases in the future. The first presentation will report on the adolescent cohort study and how it had developed over the years and contributed to interventions. Cardiovascular disease risk factors tend to cluster and progress from adolescence to young adulthood. Therefore, the second presentation will describe the clustering of CVD risk factors among adolescents in Malaysia. Having kidney disease impairs the growth and psychosocial adjustments in adolescents. Using a mixed method study, the third presentation will illustrate findings from a study entitled Kidney Health Status Among Adolescents in Peninsular Malaysia. The global prevalence of mental health problems among young people is higher when compared to other age groups, and this contributes to impaired physical and mental health extending into adulthood. And this has become more significant during and post-COVID-19 pandemic. The fourth presenter will present her findings from a longitudinal study of psychological distress and its associated factors among youth in Peninsular Malaysia. Studies have found that physical activity improves cognitive and memory functions in the brain. Our last presenter will present about physical activity and its relationship with academic achievement among Malaysian adolescents. And now, moving along to our session, I would like to introduce our first speaker, Professor Dr. Hazrin Abdul Majid. Prof. Hazrin is from the Department of Social and Preventive Medicine, who heads the Center for Population Health, or CEPH. He is a trained dietitian and has made extensive scientific contributions through the Malaysian Health and Adolescent Longitudinal Research Study on MyHearts. He will be speaking to us on adolescent study, from cohort findings to an intervention. Please welcome Prof. Hazrin.
Thank you very much, Prof. Nick, and thank you, Dr. Jasmine, for the very, what we call it, allowing our cohort study to take the first theme for the Celebrating Innovation, Industry, and Community Engagement. Thank you to all the, what we call it, participants or the audience who are coming today. Let me just put my slides. Let me walk through you the journey from what we had achieved since 2012. So today is actually 2020. This year is 2022. So we will discuss a little bit about what do we discover about the from the adolescent study. Showing? Oh, it's not showing. Do I need to share? Brilliant. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh and very good morning. So today this will be the outline from my presentation, and we will discuss about two different projects, but at the same time all the other speakers who are currently doing PhD or DRPH will be explaining what are the findings from their session. So as we know, Malaysian, we are very good when it comes to food. We are also excellent. That's why we always win with so many competitions out there, either becoming from the MasterChef UK or also become the butler for the late Queen E. So it's not surprising if you're looking at the statistics for obesity among adults in Malaysia, we are the champion, and we are the number 2 for the children and adolescent. So compared to Singapore, which is slightly more, not say slightly, they are a developed country, we are still the champion. So we are actually quite a champion for a few things, which is, if possible, try not to be the ungood ones, okay? So if you look into the presence of risk factors among Malaysian adults, so I'm trying to walk you through Malaysian generally, from the Malaysian cohort study, we know only 25%, 1 out of 4 Malaysian adults literally have no risk factors either from hypertension or 2 other risk factors for non-communicable diseases. And if you look at from our National Health Mobility Survey that we are conducting, or the Ministry of Health conducted every 5 years, we have about 63% who are having NCD, almost 50% hypercholesterolemia, and steadily between 30.3% to 33% having hypertension, either diagnosed or underreported or unreported. So if you look into the current situation, we are not actually going towards what we call it a healthy nation if it's no intervention conducted in the earlier stage. So is there any health information when the children are younger? From the National Health, when we conducted this study back then in 2012, there's only few health information such as they have infant feeding status, how's the immunization coverage, and whether there's child development and growth, such as whether they're stunting or not. Okay? So looking at that, while we are focusing on adolescents, if you look into these statistics, we are actually about 1/6 of the population. Oh, the slides are not friendly with me. Okay. 1/6 of the population. If you look at the current census up until 2023, we are just about the same figure as well. So that's why I'm just choosing to use this slide. Okay, so if you look into here, there are quite a number of them who are entering from adolescence to adulthood that we need to take care of. And more alarmingly, you have to look at why we're saying that. So the whole study from this cohort that we conducted since 2012, we are looking at the prevalence of CVD risk factors among adolescents in Peninsular Malaysia. In the beginning, when we planned to do this back then in 2011, we tried to recruit as many universities who are interested to do, but at the end, there's only one university who actually managed to get fundings, and we are continuing with it from the University of Malaya. So we are looking at how lifestyle factors operates in early adolescence affect your cardiovascular, lung, and bone health. And we call it as My Hearts, okay? And this is the logo. So this is how it looks like, the My Hearts cohort. From 2012, we follow them up from those who are aged 13 years old. I'm not sure whether some of those medical students here in 2012, you are already that age, isn't it? 13 years old? Oh, wow. So you can see if they are from one now there are some of them are medical students here. Okay. I know when we follow up, there's only one or two of those group who are becoming nurse or something. But yeah, so then we follow them up every 2 years. Up until we anticipate to follow them up when they are adults. So this is another group that we are focusing at. And then I will explain a little bit about the intervention that we did after we secured our Newton funding. So if you look into it, so we went to several schools in Peninsula. So it's actually a prospective cohort study, Central and North Zone of Peninsula Malaysia. Excuse me. And we followed from 13 years old to 17. And these are the 3 states that we look at, from Perak, Selangor, as well as Putrajaya. So the school encompasses of both what we call it urban and rural schools. There are about 15 schools that we follow them up. So the sample size that we follow up from 1,361 completed from saliva, cortisol, we follow them up, blood, some questionnaire, and then as well as few other physical measurements. And all those measurements for hypertension, what we call it BP and everything, done by our medical officers. So this is how the collection process looks like, because we have to get both consent parents as well as the children or the adolescents. They came fasting. Can you imagine asking them to actually fasting to collect their blood? But they are very good students. And then we start the registration process, and we start our what we call physical assessment straight away to do blood taking, so on and so forth. So the dissemination, what happened with most studies that have been conducted before? We always, researchers only focus to collect data and then do it for publications. But what we did, and this particular work, what we call it, been not to say applaud, but acknowledged by Ministry of Education, because we also disseminate the informations. We need to check by our pediatricians what's the results, or any of the medical officers, and then we inform if they need to follow up to the hospitals, and if they are anemic, they need to be followed up straight away. We will ask them to follow up with the Pejabat Kesihatan Daerah so that they can straight away send to the hospitals. So it's pretty much like a screening, and that's how we've been doing for the past 5 years when we are doing the collection. So these are the results. For those who are interested to know more, we published the study protocol. But at that time, we already start to see about 23% of our adolescents are their overweight, obesity. So if you look into our Malaysian data, when they're adults just now becoming almost 50%, they start from young, okay? So quite a number of them having as well higher LDL cholesterol compared to the HDL. So that's not a good sign to begin with. And if you look into metabolic syndrome, so as an overall, from that 1,000 plus participants, we have about 2.6% who are fulfill the prevalence of metabolic syndrome criteria. But if within those who are overweight, obese, about 10% of them having metabolic syndrome already. And let's focus about diet and nutrition. So we know Malaysian, even though if they travel or they study overseas, the first thing they will keep on looking at is actually food, and they look for roti canai, nasi lemak, and so on. So no matter where they are, their heart is still with food. Okay. This is my master's candidate who actually previously published this work. We're looking at the baseline of the dietary data intake, where we're using 7 days diet history, which is recommended for what we call it adolescents. And what do we discover? We discover the fiber intake is very low to begin with. It's about 3 gram. And average for adolescents, we need to actually having from 20 to 30 gram. So that's the beginning. For your crude fiber is low, and you know the consequences later for your colorectal cancer when you're adults, so on and so forth. The sodium intake, when we look into the current MyCost study, we are taking about 7.9 grams of salt. Look at how is our sodium intake based on dietary data as well. They already exceed the WHO recommendations. This is WHO recommendations for adult, not more than 5 grams of salt or 2,000 milligrams of sodium. But when they are young, at 13 years old, they already exceed. So can you imagine what's going to happen if no further healthy lifestyle intervention is given? But also when you look into those who are overweight, obese compared to normal weight and underweight, those who are overweight, obese pretty much are taking more energy, sugar and fat And surprisingly, we noticed those from the rural, what we call it, area who consume more energy compared to the urban, because we always assume the urban who are actually having more. And to make it short, this is how it looks like. Their common foods that they consume in terms of cereal, from cooked white rice, and of course your nasi lemak. And then for meat, poultry dishes, from fried egg, fried chicken, chicken soup, and masak gulai most of the time. And let's have a look. We also had the opportunity, because most of the time, we only know if you skip breakfast, what will happen to reduce weight or maintain weight, or you gain weight. So this is work that we did. So we look at those who really skip breakfast, what will happen, okay? Those who are actually having breakfast on a daily basis, they have significantly lower. This is associated with lower BMI, lower total cholesterol, as well as the LDL cholesterol. Okay, so if you skip breakfast from this group, you have the reverse. You have higher BMI, higher total cholesterol, and higher LDL as well. So even though as just looking at skipping breakfast, there's altering in terms of your blood profile. And when we look into the vitamin D intake as well as calcium, those who are inadequate, there's nothing new, is positively associated with the bone mineral content. We did as well to look into the bone mineral content. Of course, we don't use DEXA, but we are actually using from the ankle to actually really look into how's the bone mineral content. And then this is the findings from another master's candidate. So we also look at how's the vitamin D level. Knowing Malaysian, we are at the equatorial, we always have enough sunshine, but when the sunshine is there, we are inside here, we don't get enough exposure, we put our SPF 15, SPF 30 to make it even worse. So our vitamin D deficiency in Malaysia at the age of 13, you can see already high prevalence of deficiency, about 80%. And the main risk factors got to do with gender, ethnicity, and the place of residence, and in relation to your overweight, obesity, where your vitamin D circulations will be what we call it less. But when we look at in terms of clothing style, even we look into whether the cloud actually minimizing the vitamin D that is going to be absorbed. This is another work by our pediatrician, Dr. Dr. Kwa, and we noticed the prevalence of vitamin D deficiency at the age of 15 is 33%, and those who are actually more prominent in terms, those who are actually obese, having lower vitamin D compared to those who are normal weight. And you look into those who are female, Malay, and Indian are wearing long sleeves, more likely to have vitamin D deficiency. So, because we do have a lot of high-risk behavior we are looking at, but what are the things that we are investigating? We look into exposure to substance use, tobacco, alcohol, illicit drugs, gambling, and online pornography or violence. There's some of them, about 20% have started smoking before the age of 10, okay? But I'm not putting all those informations. My colleague here, Prof. Nick Daliana, look into from the baseline, what do we discover, and the studies show about 5% of adolescents aged 13 reported high-risk behavior and tobacco use at 9%, and watching violent content using internet 5%. And most of the time, it is actually seen mostly those in urban. So you see, when it comes to high-risk behavior, it's slightly a bit different than the normal, where we always look rural is more than urban, but when it comes to high-risk behavior, it seems like urban is more than rural. Of course, you can justify maybe they have better internet access, so on and so forth. So, enough of cross-sectional analysis association, because this is a cohort study and the other panels will also talk about the cohort findings. These are the studies that really look into as well as what we call so many things during exam, which is quite important for us to actually look at. So look into here, besides than just the non-communicable disease that we're looking at, we investigated muscle strength, anemia. So you see anemia, it is still there, even though we thought so it's an old problem. Overview of the risk factors of developing NCD later will be discussed by Dr. Nitya Tangaya. So muscle strength. So how many of you definitely know that we are strong to begin with? Anybody want to raise hand? Okay, we are actually number 5 out of 6 who are actually quite weak if you're looking for adults population, okay? overweight, obese, the weak. So tell me about it. So there you go. The list goes on. So this is work by Dr. Ng Aika. We look into follow them up in terms of muscle strength when they are from 13 to 17. I don't have to go in detail because it's so what you can see here, when we evaluated the relationship between dietary intake and physical activity as well as muscle strength among these adolescents, so you can see significant increase. Of course, we look into tender staging of the children as well, but when we are actually looking into here, for male, the muscle strength is gained more, but not so much for female. And this is worrying because by right, this is the prime age that you should actually develop more into your muscles and you're very active. But one of the things that we notice for male, even the drop of physical activity is still greater than the female. And female, even the physical activity level or scores is actually dropped very, very much compared to the male counterpart. And this is using the GE analysis as well. And when we look into it, the dietary intakes, energy and macronutrients increased initially but plateaued for those age 15 for both sexes. But what is important here, we don't see much association for female, but for male, the more that they're taking protein, we haven't had the chance to look into high biological value protein or low biological value protein, but we're taking it as a protein as an overall. There are few works is ongoing. We look into dietary pattern as well in the future. Carbohydrate intake among males were associated with higher muscle strength, but was not observed in females. We're still not sure what is it, but one of the things that we can hypothesize is lack of physical activity. There's so many other research being conducted within this, but I don't think so we have time to go through. And just now we look into the anemia. So this is looking at the longitudinal relationship between nutritional status and anemia among Malaysian adolescents, done or what we call it follow up by Dr. Vanita. So what we discovered that is published here, we know for the whole family is not only having problems with overweight, obesity, but if you look into here individually, some of them is actually micronutrient deficiency, some actually the mothers who are inadequate of dietary intake, also having anemia, and few other things that's going to relate. So if you look at the population, both undernutrition and overweight prevalence is the same in the community, region, or nation. So it is actually a worldwide problem. So look into here, the dietary intake of adolescents, because we have to follow up those who are really gone through with us, and after we cleaning the data, so we see from this 528 at the end. So those who did not meet the recommended nutrient intake that is been suggested, for daily total iron intake have 51.7% increase in the risk of developing anemia. So when we look into it we don't just use hemoglobin because we have complete full blood count. We also look into the Mensa index. So we monitor in terms for the how is it going to be. So 51.7% increased risk of developing anemia compared to those who daily recommended nutrient intake for iron is met. And from the GEE that we analyzed, the more complex analysis from the statistical showed that those who did not meet the RNI for iron significantly higher risk of anemia by relative risk of 1.776. So it is still a problem. So this is just a quick snapshot because we find it very difficult to conduct any study not having a validated tool in Malaysia, especially for dietary. So what we did is basically we developed and we patented in terms of the food frequency for adolescent. So just to snapshot, during the study, we are using 7 days diet history. So basically, we literally need to ask them every day what they are taking. This is done all by the trained dietitians to ask them. And then once we have completed the informations, then we tabulated, we do the proper analysis, and we had developed the food frequency questionnaire. If you are interested, you can look into some of the papers that we had published. And pretty much they have a good intra-class correlation. So basically it's validated and can be used for those who are interested. Most of the things is already in this book. So why I'm actually come up at the end with a book, because it's finally, I find it very difficult when you conduct a study in Malaysia. Some people are actually doing patches of here and there, but they wouldn't be able to share. So the best thing is actually once you develop everything, you put it in a book. Who is interested, you can buy it. So some of this has been already used in other counterparts, Indonesia and few others. All right, so what we do, that is the publication. So enough about food. Now we are talking about physical activity. So we know from the physical activity as well, are they good or not? So we look into physical activity questionnaire. I'm sure with our young medical students here, you always exercise all the time. I noticed that in the evening. Not exactly all of you, but but that's good. Continue and maintain it. But we're using the step test because this is what we call it common that been used for Sega and few others at schools. And what we notice, even though at the age of 13, this is cross-sectionally, already 43.3% already have unacceptable level of physical activity. Can you imagine? Adolescent stage already unacceptable, let alone when we become adults, okay? All right. So because this is quite a big what we call cohort study, we had opportunity to work together with those who are in pharmacology who came in, who wants to do and investigate from SNPs, so single nucleotide polymorphisms and physical activity. This is done by currently student masters Dr. Hanisa and together with Prof. Zahurin at that time. So what we discovered, those who are having higher PA, it was shown having lower percentage of body fat, which is good, but these are the SNPs that is related that we discover associated with percentage of body fat. Okay, but work with this. We only published one. I'm sure it's actually more to come. We look into physical activity just now from the muscle strength, but it's not surprising to see here physical activity at the age of 13 to 15. The downward trend of physical activity is mostly reduction in all, especially in the rural adolescents, and definitely for the girls residing in rural. Okay? More work needs to be done to understand why and maybe to provide the environment that is suitable for them to exercise as well. Okay? And females experience more because you see, even though if you're living in somewhere, a new place, definitely the higher income economy is getting better when there's a new pop-up of McDonald's or Starbucks, you see? So that is indicator of that a place is actually quite good. You can find it even though if you go to Tower Sandakan, you can see the Starbucks there. So you see what we call it, that's how one of the things to look into economy. This is longitudinal assessment with the lifestyle and related risk factors with the composite cardiovascular, which is going to be, we publish in scientific reports. I'm not going to tell you in detail because we have our speaker here, Dr. Nitya Tangia, who will explain with her, what we call it, pioneer work when she's doing different assessment using statistical analysis. Okay, you can have a look, and both work has already been published. And by looking at all those things in life, basically, if we want to minimize our chances of developing NCD, work needs to be done. We have Prof. Tong here, who are actually from pediatricians. A lot of work needs to be done from young, from peds, as well as another one is actually during your adolescent. So whatever that you are doing during the peds and adolescents, it can actually reduce your trajectory of developing NCD in the future. Okay? So, I'm talking just now about the My Heart's cohort. Now I'm talking with the My Heart Beat when we had this, what we call, received the funding, Newton Fund, to look into what sort of intervention for this group. So this is where I got it together with my colleagues from Bristol, Dr. Laura, and we're trying to see with the information that we have, what are the things that we can plan for the intervention. So there are 5 objectives. First, to identify behavioral patterns, to examine associations with clinical cardiometabolic risk factors, systematic reviews that we did, and then we try to look for metabolic profiles. This is ongoing work, which we are currently working on to really look into the metabolic composite and how do they actually develop in terms of the cardiometabolic risk factors. Intervention study that we did, this is just happened before pandemic. So luckily, everything done just before COVID-19. Otherwise, I won't be able to share any knowledge with you guys. Pilot test and evaluate behavior change program in Malaysia. So for those who are familiar, I just want to repeat. Basically, we are using the MRC framework where we need to actually identify the evidence and then we must test them in terms of feasibility and pilot for the intervention that we are doing. Then we evaluate whether it's effective or not, whether it's cost effective, and at the end, then only if it's better, we need to actually scale up, then we need to implementation stage at the larger scale. Of course, MRC Framework 2021 has changed a little bit, slightly different than this. It has 5 diagrams. So, what we noticed from our systematic review, basically males who are more physically active compared to female, but unfortunately from the findings from the systematic review means we pull all those information from published in Malaysia, but they tend to have poorer diet quality as well compared to the female. And also, when we look into their diet and physical activity to cardiometabolic health among Malaysian adolescents, we discovered there's lack of evidence from the well-conducted prospective studies on the effect of diet and physical activity. So when we discovered this, it's very difficult when we want to do intervention to combine both physical activity and nutrition, or we are just doing only with one. So at the end, when we want to see really the effect, we just decided to focus with intervention on nutrition, because if you're doing two ways, it's very difficult to entangle which one actually giving more effect. Okay, so before we start the intervention, we did a qualitative study. For those who are familiar with qualitative study, we just want to make sure that how's the perception of eating practices and physical activity among Malaysian adolescents in Malaysia. And what we discovered, stakeholders always thought that adolescents' misperceptions, limited availability of health options, unhealthy food preferences are among the barriers to adolescents being active at school, okay? And together with physical education. Who can tell me how many times your physical activity education been replaced with other classes during your school time? I'm sure all of us experienced that, okay? Most of the time, if you're Form 3 and Form 5, that is where the classes for science and maths, okay? These findings provide important insights into developing school-based lifestyle interventions to improve physical activity. For your information, Ministry of Education provided 3 times per week for physical activity. I'm not going to explain more, but if you are interested, you can ask me. So when we discovered all these things, we need to develop a proper protocol looking at how we're going to have what we call it, the study to be conducted. So this is our logic model that we look into, because if you're using the MRC framework, you must be clear with the logic model that you want to do. So this is the intervention one, where we are just training using the canteen and school convenience shop to provide healthy foods. But intervention 2, we are providing some subsidies, because when you're encouraging the canteen operators to provide more fruits and vegetables, they always have in their mind saying that students don't want it, it's going to be expensive, nobody's going to take it, and it's going to be wasted. So you need to understand this scenario first before you develop anything, because as a researcher, you tak boleh buat study shock sendiri. You think what is correct, just do. Okay, forget about it. If you're planning to do that, just keep your money and do something else. Okay. So the control is status quo, the one that normally Ministry of Health and Ministry of Education doing, and we try to see whether we evaluated them. So we did process evaluation, and then we monitor in terms of the dietary intake as well. So this is the intervention that never been done before, using the subsidy for fruits and vegetables and low energy dense kueh, because most of the time you go to your canteen, there's always nuggets and everything. I show you the picture, which you can relate for those who are slightly within the 10-20 years when you're going to school. But we're trying to classify the food for the children or the koperasi, the food that should be there, green label, using the traffic light system. The one that shouldn't be there should be in the red. And by right, this is the information. We do have our canteen dietary guidelines that is produced by Ministry of Health and Education. Even though been updated in 2010, it is still not fully implemented. Okay, there you go. So we are 65 years of independence. This is some of the foods that still be available in our canteen. And what we are doing here, we are just publishing, not just publishing, but we try to inform. This is exactly what is there. Even though we have our guideline, the guideline stated no processed food or not even from burgers and everything should be there, but you can still find that. Okay, right. Because when they come to see you at the hospitals, they just come out for one-off. But what they are consuming for the past few years is already there at school. And even worse, if the parents who are packing those food for them to bring it to school. Okay? And until when we did the study, there's no guideline of food that it should be there at the koperasi. To begin with, your koperasi or your bookshop shouldn't sell any food. Okay? So this is where the bookshop with the food that is selling. And I understand why they sell food, because there are thousands of students. When there are a lot of students, not everybody want to queue at the canteen, because the queue at the canteen will take longer. So they will opt for food that is easy to get from the koperasi or even though for the other shops, right? So these are the facilitators and barriers when we are trying to implement. So we did a qualitative to look at it, and what we discovered basically, the subsidy or the coupon really help in terms of improving the acceptance, because we challenge back the food canteen operators saying that the children will don't want to eat vegetables. Whenever we put it there, we present it well, it is there as long as actually at a reasonable price. I'm almost there, finishing. So this would be the outcome evaluation. So we managed to fulfill all our objective for the study. But just if you are interested, look into this paper. We did from the pilot work, it works. It works in terms of people can accept if you are even though changing the way you are cooking at the school canteen, because always there is perception it's not going to happen unless if it's actually at a private school. No, it's not. This we did it at the national school. So, but we need to confirm more from a larger study to confirm this finding. So these are the conclusions. We need to reach out. How many minutes more I have? Okay, almost there. I got 4 more slides. I think that's fine. So reaching out, whatever our research findings, don't just keep on so excited to publish it in journals, but you also need to translate it back from your health professionals, policymakers, schools. You have no idea how many times I try to beg the Ministry of Education to listen to my talk. But of course, once they like to listen, the only one thing that they are looking forward from my work now is actually about the exam results for physical activity, which we have not published, okay? But other things, they are also interested, but you have to really play your role to reach out to them. And also your academics. So that's why I think it's good with the Faculty of Medicine Research Carnival, where there's so many research being conducted, we need to inform our colleagues so that if they plan to do something, if those who have already been conducted don't do it, and you do something new. So I did put it here for public health significance. Diet, physical activity really help in terms of improve your mass strength at the end. As a reflection, when you're older, if you are lower in terms of muscle strength, it's a reflection how our early life, we might not that strong. And I think, to be honest with you, those who are at this, for those who are now who are older adults, I'm sure they are much stronger if you compare to those who are now, because their life and everything, they walk to schools compared to now, even though if possible, the car really parked in front, not even the school, in front of the class, okay? Some parents are so paranoid about their children's, of course, we need to take what we call about safety as well. So I explained a little bit about the intervention. So this would be the impact. Short term is good for researchers, but at the end, whatever that you found, you need to engage with the relevant stakeholders, even though with the food industries. Currently, I'm working with another Newton project. We work with the Association of the Canteen Operators. They have association, yeah? School to provide new evidence, policymaker back to the NCD and school health program. This is a long way to go. Society and economy helping to improve current food environment within schools hoping to improve adolescents' nutrition intake and better health. Reach out to people. Put it there during the news. Put it there in the magazines, okay? And this is my opportunity to learn from the guru of nutritional epidemiology, Walter Willett, when I was at Harvard. And also keep on shouting to the people either in the news and also, one thing good when during the COVID-19, they invited me for, last NTV7, they have this session for the school children. So I was invited as well to talk about Melindungi Remaja Membina Juara, and then that's really managed to get some audience and they actually get the feedback. So all the findings you need to translate back to the community. There's no point you actually being in the university if you didn't reach out to the community with your findings, okay? But this will not be happen. This is basically, it's not going to happen, sorry. If it's actually, this is my team. Of course, I'm the principal investigator. But in the initial stage, it was led by Associate Professor Dr. Nabila for the baseline. And then after that, for the cohort, I need to find the fundings more. And then Prof. Yazid is one of the co-principal investigators. But you can see the list of investigators is quite a number. And I have to thank the fundings. Of course, it's a struggle to get fundings, but without the funding, this study won't be, it's not going to be materialized. These are the My Heart's Beat members from our Bristol counterpart together with our local counterpart here. And these are the lists. I don't put the whole list. This will be the list from the postgraduates graduated using when we work together for this cohort from Masters by Research, Doctor in Public Health. There are a few more today after this, and PhD Dr. Nitya, who's going to talk today. That's it for me. Thank you very much. I think I switch close this. Right, Nitya, right? Okay.
Great. Thank you very much, Prof. Hazrin, for sharing all the interesting findings from my heart. We've got one comment here from YouTube. Excellent work from the team. Many publications with impacts. Congratulations. Congratulations again, Prof. Hazrin and team. Okay, and now we shall move to our next speaker, Dr. Nitya Tangia. Dr. Nitya has been involved in various projects on population health at Center of Population Health. Her research interests include data management and data analysis. The title of her presentation today is Clustering of CVD Risk Factors. Please welcome Dr. Nitya.
A very good morning, everyone. I'm happy to be here today to share a portion of my findings from my PhD. Thank you so much, Prof. Hazrin, for all the introduction towards the study. The topic of my talk today will be on clustering of biological CVD risk factors among adolescents in Malaysia using findings from the MyHearts. So this is the outline of my presentation today. A little bit on the background. So, as we all know, non-communicable diseases refer to non-infectious diseases that do not spread from one person to the other. It comprises of diseases like diabetes, respiratory diseases, cancer, and CVD. So CVD here, cardiovascular diseases, refer to the disorder of heart and blood vessels and results in chronic diseases such as heart attack, stroke, heart failure, and many more. Globally, there have been 34 million deaths that were reported, and out of the 34 million, about 17 million were accounted for deaths by CVD. Similarly, in Malaysia, if you look at the country profile here back in 2014, out of the 146,000 deaths that were reported, 73% of the total deaths were estimated based on NCDs, and out of that, 36% were due to CVD deaths. So, hence the reason why we need to look into the risk factors for CVD, which include hypertension, hypercholesterolemia, overweight, obesity, and diabetes. From the findings from NHMS 2019, as you can see here, the prevalence for hypertension was at 30%, for hypercholesterolemia was at 38%, obesity was at 50%, and diabetes was at 18%. And these were all rising from the past few decades. What is even worse was to find out that the clustering of all these risk factors, the coexisting comorbidities, were at 43.2% of a prevalence in Malaysia, which means there were 2 or more CVD risk factors that coexisted in the population. And the reason why we need to study this is because eventually the country is going to suffer from loss of productivity, and we are probably going to go towards a sicker population. So preventive care is important to reduce the healthcare expenditure for curative care. And the reason why we are targeting adolescents, if you were to look at this diagram here on my left, a study by McMahon in 2008 showed that fatty streaks start to accumulate at the very young age of 9 to 10 years old, and it continues accumulating and manifests itself only at the age of 40 to 50 years old, and that's where you have all the different diseases coming in play. Having said that, so the objective of my study was to cluster the many different CVD risk factors at the age of 13, 15, and 17 years old, and to track the clustered biological CVD risk factors and characterize the patterns of cluster transitions. So a little bit of repetition based on what Prof. Hazrin had mentioned earlier, simply because I was using the same study. So the study timeline here refers to, it was 3 time points. We looked into 13-year-olds in 2012, followed up with them when they reached 15-year-old in 2014, and finally when they reached 17 years old in 2016. And the study area involved 3 states of Perak, Selangor, and Kuala Lumpur. 15 schools of urban and rural schools were selected. Population size came up to about 1,320, and about 637 maintained throughout all the 3 time points. Data collection, as usual, we used self-administered student questionnaires. Clinical blood tests were done on various tests, anthropometric and BP measurements. And in terms of data analysis, we used, we use a 2-stage hierarchical and K-means cluster analysis using SPSS. So the concept of clustering here, basically, what was being done here was to actually identify the CVD risk factors. In this case, we identified 8 different CVD risk factors, including systolic, diastolic BP, the lipid profile, as well as waist circumference and body fat. And what we did was to use the clustering method in order to identify if an adolescent belongs to a high-risk cluster, a medium-risk cluster, or a low-risk cluster. And once this was done, it was repeated for when they were at 13 years old, 15 years old, and 17 years old. And upon doing that, we could actually identify if the adolescent were actually the transition from a lower risk cluster to a higher risk cluster, if there was a transition happening. And results from the study. So in general, the study comprised of more females, Malay ethnic, and slightly more of them from urban population. And most of them, the majority of them were from household incomes of less than 1,500. In terms of risk factors, in general, females had a slightly higher body composition compared to males, and males had slightly higher blood pressure and lipid profile readings compared to females. So these are the results of the study. So what I found here was that, as a matter of fact, using the cluster analysis, there were 3 distinct clusters that were formed: high-risk cluster, medium, and low-risk cluster. So in 2012, among those aged 13 years old, I found that 26% of them were in high-risk clusters. In 2014, 19% were in high-risk clusters, and 2016, 23% were in high-risk clusters. And from 13 to 15 to 17 years old, 12% remained in high-risk clusters consistently. And looking at the statistics, among all those who were in high-risk clusters, they were statistically significantly higher compared to all those who were in low and medium risk clusters. In terms of profile transitions, I found that from 13 to 15 years old, there were adverse profile transitions, about 15.5% was the prevalence. And from 15 to 17 years old, the adverse profile transitions were about 19.5%. Adverse profile transitions means moving up to from a lower risk cluster to a higher risk cluster. And similarly, for those who maintained in high risk clusters, the prevalence were about 13% for both the transition periods. So this is basically a cross-step of between the risk classes between both transition years. And kappa values showed that there were rampant transitions in between all the cluster groups. This was also another model that was statistic model that was conducted using logistic regression to identify the risk of attaining a high risk cluster based on your former risk cluster. So it was quite worrying to find out that let's say if the chances of an adolescent who was at high risk, who belonged to a high risk cluster at 13 years old, that adolescent was at a 33 times more, had a 33 times more chance of belonging to a high risk cluster at 15 years old. And similarly, if that adolescent was at a high risk cluster at 15 years old, they were 31 times more likely to belong to the same high risk cluster at 17 years old. And this were controlled for some other socio-demographic characteristics. So the reason why clustering was important was because if it was compared with some other methods, the other methods seem to underreport the prevalence, and there was quite a bit of loss of information there. So the clustering method, especially the k-means and hierarchical clustering method, seemed to be quite accurate in reporting the prevalence. These are the strengths and limitations of the study. First of all, the strength of the study is that this is the first cohort study in Malaysia and the first study in Asia to measure clustering CVD risk factors among adolescents. The longitudinal aspect of the study allows us to measure the association of CVD risk factors among adolescents, and a standard measurement of clustering is useful to group clusters of CVD risk factors of similar characteristics rather than dichotomizing them. So the conclusion here is that clustering seems to be a better option for grouping adolescents at risk with similar characteristics, and a sizable number of Malaysian adolescents either remain persistent in high-risk clusters or have adverse profile transitions. Public health recommendations, we really should have more healthy meals provided in school programs, as highlighted by Prof. Hazrin earlier. We should really strengthen the current physical education programs in the existing schools, elect student health ambassadors, maybe have a one spot, one student program, ensure lifestyle coach programs to ensure full-time nurses are stationed in schools to monitor the students' BMI and physical fitness, initiate a CVD health monitoring system, perhaps, and also probably provide targeted intervention for identified groups, especially those who are at risk of adverse profile transitions. And these are the two publications out of the study, if you're interested, and some of the oral presentations over the years. Thank you.
Thank you very much, Dr. Niti, for addressing this important issue on clustering of CVD risk factors among adolescents. We shall now move on to the next presenter, Dr. Fathullah Azmi Nawawi. He is our Doctor of Public Health alumni. He is currently working at Kuala Selangor District Health Office. He's very passionate about adolescent health, and today he will present his study entitled Kidney Health Status Among Adolescents in Peninsular Malaysia, a Mixed Method Study. Please welcome Dr. Fathullah.
Thank you, Prof. Nick. So, Assalamualaikum and very good morning, everyone. So, thank you for inviting me today. So, I'd like to share my findings on regarding my DRPH project, which is entitled Kidney Health Status Among Adolescents in Peninsular Malaysia, a Mixed Method Study. So, why adolescents? Important is important. Okay. Majority of adolescents actually live in Asia, right? And in Malaysia, we have about 18% of adolescents. So even though they make up of a big group of the population, but many things has been taken granted and not managed properly, and it include CKD as well. So let us look at the CKD burden in the world. Most of the data nowadays actually it was from CKD registries or hospital registries or the national registries. So the incidence actually around 15 to 74.7 per million population in the world. And those actually data were from high-income countries. We do have CKID study, NANE study, which actually one of the biggest study that looking into kidney health, kidney function status among adolescents. Okay, most of the study actually cross-sectional, and I think there's two notable cohort study, which is the CKID study as well as the ITALKID project in Italy that was done many years ago, right? The biggest population-based study was from the NANES data in the US. Okay, there's no study actually was done in Malaysia, all right? So when we look in Malaysia, the incidence and prevalence actually increased for the past 10 years, even though it's small as compared to adult. But from 2007 to 2016, we realized that the increment rate of dialysis patient among young adult aged 25 to 34, it increased. Actually, we have a larger increment rate of 57% compared to 35% in those more than 65 years old, right? So when this ISN report also showed that many part of the world we are still lacking in terms of CKD management. We don't have any existing CKD specific policies. We don't have any detection program, and there's very lack non-dialysis CKD registries in the world, although there are some in the high-income countries, right? So from there we realized that there's so many research gaps. So the current data actually based on hospital or national registry, and knowledge on earlier stage of CKD is very lack, because what we have is only those at late stage 5. Okay, and in the policy part as well, the global mandate was initially lacking. It was not highlighted in the global mandate, in global policy, until in 2018, where they rectified again. That's where we come up with our own policy in Malaysia. But again, it was for adult. So we come up with this study. We do have the general objective of this study is actually to investigate the relationship between kidney function status with the potential factors that lead to its changes among adolescents in Peninsular Malaysia. And we have 3 other specific objectives, which is to investigate kidney function, determine their lifestyle and health factors, as well as exploring the available policies for kidney disease management among adolescents in Malaysia. Again, this is a repetition from basically this is part of the MyHeart study. We use the MyHeart data to analyze the kidney function of the adolescents. First, from 1,361 students, we only collected about 607 students after we apply the inclusion and exclusion criteria. So those actually participated in all 3 data collection period and with available renal function included in the study. So these are some of the study instruments that we use. We assess the physical activity, the dietary intake, BMI, systolic, as well. We managed to get some venous blood sample that include fasting blood glucose, as well as the main outcome of this study, which is the kidney function. So kidney function was actually assessed using bedside Schwartz equation. Okay, so from the EGFR that we calculated, we then classified them into the based on the KDIGO EGFR classification. So these are the statistical analysis that involved in the study. So for the longitudinal analysis, we actually use generalized estimating equations based on 3 different models, which involve the mean and interaction with time effect, right? For the qualitative part of the study, this is to cater for our specific objective number 3, right? So we did an in-depth interview that involved kidney health personnel in Malaysia. It involved both the pediatrics as well as the adult side. Initially, we planned to actually recruited 31 participants, but due to multiple reasons, we managed to get 10. By the end of March 2020. But we reached data saturation at the 9 participants. So we did an interview. It lasted for about 45 to 60 minutes based on a pre-prepared interview guide. We explored the policy issues and challenges, future plan for CKD as well as adolescents' need. So results and discussion. So out of the 607 students, most of them actually female, similar to Nitya's study. Most of them actually live in the rural areas, and these are the baseline characteristic of the students at baseline in 2012, right? So going to our specific objective number 1, which is to investigate the kidney function among the adolescents. So from here, we can see that EGFR of the students actually have, high percentage of adolescents already have decreased kidney function 60 to 89 mils per minute in 2012. It increased from 6.1% to 30% and also to 40.2% by end of the cohort, right? And to compare our result with other studies in Malaysia, so we compare with adult because since we don't have anything for children and adolescents, so we compare. Our findings actually showed higher percentage as compared to even the adult population in the country. And when we compare at other parts of the world, the percentage, the prevalence that we have is actually comparable to NANES, to the US, in the US population. However, when if we compare with Turkey or even Nigeria, a population-based study that actually look into kidney function as well, it's much more lower there than here. All right, we also actually compare the prevalence of decreased kidney function based on different formulas. All right. So the recommended equation that to be used for individuals less than 18 is actually bedside Schwartz. And when they reach 18 years old, the current recommendation is actually to abruptly change to CKD-AP. All right. So we tested all these formulas. So we found that when we use CKD-AP, the percentage of decreased kidney function even when they were at 17 years old at the end of adolescent phase, it showed a very big discrepancy with bedside Schwartz. All right. And Land-Momo revised equation actually showed the least difference percentage when compared to bedside Schwartz. Right. And there are actually few reviews before this by Potter. Potter said that the culprit for these discrepancies actually it comes from the CKD-AP, and the formula that we use, Ng and all method and also LMR, is actually the two equation that showed the least P 30% and the closest to the MGFR. So the first, in the longitudinal analysis, the first factor, the first variable that actually significant was time. So as students become older, their kidney function actually deteriorate remarkably. All right. So from here also we can see that the rate of the decrease in the first year of the study from 2012 to 2015, 2014, the rate of decrement actually larger in the first half of the study as compared to the second half of the study. So we believe it may be due to puberty, but however we did not assess in the current study. So second is actually sex. Female was shown to have higher EGFR as compared to male, even though in the evidence and also guideline it showed that it was estimated that female should have a lower EGFR as compared to male. So we believe that this happened due to the renoprotective effect of estrogens, since evidence have been shown that female with estrogen, it protected the kidney from further deteriorating. The third variable, okay, it's place of residence. Why? What we find actually, those living in rural actually having generally lower EGFR, okay, lower EGFR compared to those living in urban, right? So from here, the first thing actually is socio-economic status. There are few evidence that actually have said that socio-economic status, those having lower socio-economic status actually having higher odds for CKD. But in this study, we also found that there's higher percentage of students actually smoke with elevated BP as well as obesity in the rural areas compared to urban. In ethnicity also was significant in the longitudinal analysis. Indian student has generally lower EGFRs compared to other races, compared to Malay. And at times, Chinese was found to have higher EGFR, right? In 2014 and 2016, their EGFR is actually higher compared to Malay. There are not much evidence actually showing this relationship as well. So for overweight obesity, all right, we found that with a unit increase in BMI, the EGFR decreased by 0.47 unit EGFR, right? And those in the thinnest grade 1, grade 2, or grade 1 and 2, they showed higher EGFR compared to those having normal BMI. And morbid obese students have remarkably, very significant lower EGFR compared to those in the normal BMI. We also found there's probably dual effects of BMI to the EGFR. Why I said that? In the interaction effect, we found that at times in 2012, 2016, those having overweight and also morbid obese, they have higher EGFR. Initially, I said there was a lower EGFR, but now in the interaction effect, we found that there are times where the EGFR actually become higher. So we believe this may be related to obesity-related glomerulopathy, where hyperfiltration occur. So some other factors that actually significant with the EGFR changes, it was birth weight, physical activity, as well as dietary intake. In the dietary intake, even though the changes to the EGFR is actually quite small, but it remained significant. All right. For energy, higher energy. For energy, with increased energy intake, it reduced EGFR by about 1 ml per minute. Right. And for protein, it showed actually both changes, which is the positive and negative changes. And we believe it may be due to the type of protein consumed by the students. But however, we did not really assess that in the study. And for sodium, it showed higher EGFR when those taking above 2 gram sodium, and we believe it is due to hyperfiltration effect. So for the qualitative study, so we managed to get 10 participants. So data saturation reached at 9 participants. Mean age of participants was 45 years old. Equal male and female distribution was interviewed. Most of the participants actually from the government sector, right? But we managed to include the adult nephrologists, peds nephrologists, public health physician, and also the primary care side to get their input on this matter. So basically, we have four teams and few sub-teams extracted from the qualitative analysis. So in short, we do have a policy, CKD policy in Malaysia, all right? But it is only for adult, all right? So they don't have any CKD policy for children. We don't have any CKD program, screening program for children, but we do have for adult as well, and it only focus for those having diabetes. Unlike we do have these pediatric protocols. We do have policy options for combat obesity, management of obesity. But surprisingly, in this policy, kidney function was not listed as one of the assessment that is compulsory or need to be done in this protocol. I looked through everywhere in the policy and when it was not stated. As compared to those the management like this, I put here in the UK, they have a very robust and complete guideline that cover both adult and children population in their country, you know. And registry only for those on dialysis. We don't have anything for early stage of CKD, stage 2, stage 3, even stage 3. We don't have anything. The worst is actually in for children, right? And majority of the registry, as I mentioned earlier, it was only for in the high income countries, right? And I think the biggest issue in pediatric nephrology services in the country, first of all, they are very minimal. Okay, they are only like 7 to 8 or 9 pediatric nephrologists in the country. So due to this, they shared that they told us that they couldn't go forward and bring up this CKD agenda in the country. They just focus in their clinical work and rather than doing all other things like the public health things in the country, right? They even share their budget with the adult nephrology. 98% of the pediatric nephrology budget is actually from adult nephrology service, not adult nephrology unit. Okay, and they feel that I think we have to step up. The primary healthcare need to step up their effort for detecting those having kidney function impairment, because the main issue here we have to detect first, and that job is actually for the primary care to do, right? And there are some issue with collaboration, especially among Ministry of Health and Ministry of Education. Okay, we do have some programs in the country, but there's no proper auditing and evaluation being done, and we don't know what is happening actually down there. And when we ask whether there's any plan for NCD or CKD for pediatric or children in the country, since they have very minimal people, they don't have enough budget, so there's no future plan at the moment. So like I said earlier, we have to implement, monitor, and improve on our NCD program in the country. And they just hope all the participants actually what they hope is actually for community, parents, and adolescents to live a healthy life. Right? That's the most important thing, right? So some practical implication in this study. For public health personnel, we have to acknowledge that there's many loopholes in the service, right? There's so many loopholes, especially when it comes to this study. There's there's so much loopholes in terms of CKD management in adolescents and also children in the country. All right. For primary care, we need to acknowledge that opportunity to detect early stage of CKD lies within their responsibility and not those nephrologists in hospital. Nephrologists will only see those CKD4, CKD5, but those CKD, the early stage, we have to remember that CKD doesn't start from stage 5. It starts from 1, 2, 3, right? So we have to detect all these diseases this stage earlier. So this responsibility should lie between the primary healthcare and also the public health. And for clinician, as I stated earlier regarding the formula, probably we have to acknowledge that there's large discrepancy when it comes to the formula usage during the transition from adolescence to adulthood. So probably from bedside Schwartz to CKD-AP, something can be done in that phase. And for community, they have to acknowledge that kidney function can be affected even during the adolescence. I think most of us actually thought that when we talk about CKD, you always come back to diabetes, those 60-year-old having diabetes, hypertension. But from here, we can see that even though it doesn't go until stage 3 yet, okay, but there's so many of them actually already in stage 2 decreased kidney function, 60 to 89, which shouldn't happen, right? So for strength and limitation of the study, I think our work is actually a novel work. We don't have anything in the region, so this is the first. And power of the study is actually maintained, and qualitative component actually add on to the overall situation for us to understand what is happening down there. And we hope that our finding can actually guide in policy change. We do acknowledge some limitations. First of all, assessment of kidney function. Since the kidney function in this study only based on EGFR, which is the creatinine, we don't have the protein, so we can't actually evaluate the kidney function properly, and the hyperfiltration effect, which I mentioned in our finding, cannot be assessed. Secondly, type of protein consumed. Again, I have already mentioned that we don't actually assess the type of protein consumed by the students. So in conclusion, we report that there is a high prevalence of decreased EGFR among adolescents aged 13 to 17 years old, and the kidney function actually associated with multiple modifiable and also non-modifiable risk factors. And in terms of policy, there's no clear CKD agenda in pediatrics. It's available due to multiple issues faced by the services. And some of the recommendations from our study, what we can say is that collaboration is important. All right. We do have few things down there at the moment. We do have some programs, but many of our participants actually told us that the collaboration between Ministry of Health and Ministry of Education at school is, to say, I mean, we can improve on that. I mean, to say it's poor, I'm not too sure, but yeah, we have to improve on the collaboration between Ministry of Health and Ministry of Education. And the current NCD detection program at primary care, we have to strengthen them, all right? And probably we can do kidney health screening, probably, okay, by doing probably proteinuria. We can do some pilot study at school level, and we can compare. From there, we can actually compare the result from proteinuria with our result. And of course, we can also include some cost effectiveness analysis to say whether urine protein is a good screening method or not. All right, that's for future research. So with that, I thank you. I end my presentation, and thank you again for your attention.
Thank you very much, Dr. Fatullah, for that presentation. So since Dr. Fatullah, you have to leave for another meeting, so I think we can actually open the floor for question. However, I can only allow one question. Very sorry about that.
Any question? Yes, please.
Assalamualaikum Dr. Fadhullah. Sorry. Thank you for your presentation. I'm Nur Ilham from Pharmaceutical Services Program down the road in front of the UIA. I would like to ask regarding the collaboration with ministries, what kind of assistance per se that you feel is in need in order to make all the suggestions just now materialize? If possible, two most important collaboration in the near future so that it can speed up.
All right, thank you. That's a very good question. It was actually asked in my DRPH Viva. So I don't know. Okay. First of all, okay, let me see what is the issue with collaboration between Ministry of Health and Ministry of Education at the moment. This is basically how I am going to answer this is actually based on my findings here. So from the participants, what they can say. First of all this NCD program, there's so many stakeholders that actually involved in this in the program. All right. So I think what we need actually probably one or two focus program conducted by Ministry of Health and Ministry of Education. If I enlisted the programs that currently being done at school, there's probably about 9 or 10, right? With the same objectives. That's one. Okay, what we can do actually being focused. All right, being focused, they come out with a solution, come out with a program, probably a single or two, probably single program is also enough. All right, single program with the same objective. We share the same objective. The problem is different ministries have different objectives. All right, we have different KPIs. Okay, from Ministry of Health, we do have one KPI, but do you think the Ministry of Education want to actually work with us to ensure that our KPI reach? They have their own KPI for their own program. All right. So what we need actually is one, we have to sit down. We have to sit down and discuss how to actually get, only one standalone program that actually focus in one objective, so that we can share the same objectives lah. All right. And secondly, we from Ministry of Health, we instruct the teachers at the ground level to do few things for us. All right. But unfortunately, training is very lacking. All right, training, we don't know. First of all, do we have any study that actually showed whether the teacher is actually willing to do all this? We don't have anything. We don't have anything. Even the current program that we have, there's no data, there's no evaluation that has been done. We don't know what is happening down there. Right? So we have to get that. We have to see the overall picture. We have to see what is happening down there, what is the issue, where we can improve, so that we can come up with a better solution for that. I think what we need the most now is actually proper evaluation. We do have some programs down there. But another thing, from the feedback, okay, let's say we have one program under Ministry of Health. All right. Just now I said that probably the collaboration between Ministry of Health and Ministry of Education is not up to par. I think the collaboration between units in the Ministry of Health is not up to par also. All right. Probably this one program was given to probably nutrition unit in Ministry of Health, but you see, they don't make full use, let's say, obesity program in district, all right? The collection of data and everything, it comes straight to the nutrition unit in KKM, all right? This is from the feedback, all right? So those family medicine specialists at ground level was not involved. So I think before we actually pointing our finger to collaboration between Ministry of Health, Ministry of Education, we have to see ourselves what is the collaboration, whether we have achieved a good collaboration between units in the Ministry of Health itself. So because this is our program, this is our forte. So we have to make sure that we do it right first. All right? So, yeah. How many already? And I think one more thing, everyone should realize that health is important. Okay, we will strive for our best to make sure the children and adolescents' health is well taken care of. But as Prof Hazrin mentioned earlier, how many of us actually being the physical activity classes being replaced by other things? Because the priority of the teachers of non-health personnel is actually not like us, which is health. So we have to make sure people understand that health is priority in our life. All right? Does that answer your questions? Right. So thank you so much again for your attention.
Thank you very much, Dr. Fathullah from the Ministry of Health Malaysia. Okay, so our next presenter is Dr. Noraini Aziz. Dr. Noraini is a DRPH candidate from Pejabat Kesihatan Wilayah Persekutuan Putrajaya who has a great interest in adolescent mental health. She will share findings from a study entitled A Longitudinal Study of Psychological Distress and its Associated Factors Among Youth in Peninsular Malaysia. Please welcome Dr. Noraini.
Okay, Assalamualaikum. Very good morning to everyone. First of all, I would like to thank Prof. Hazrin, SPM Department and University of Malaya for inviting me to share my study findings on psychological distress and its associated factors among youth in Peninsular Malaysia. And I'm Noraini Aziz from PKD Putrajaya. Okay, a little bit on my study background. Youth is defined as transition phase from adolescent to adulthood from age of 15 to 24. And in Malaysia, we define youth as the person between age 15 to 30 years old. And why youth is so important? Youth involve transitioning from childhood to adulthood, which is from dependence to independence, where they start to taking adult role and transitioning from school to university and start to have financial responsibilities. And during this, for this all responsibilities, they need to they need to adjust and they need to adapt to the new changes. And psychological distress is the indicator of mental health problem in the population and is often used in public health studies. It is defined as state of emotional suffering characterized by symptoms of depression, anxiety, and also somatic symptoms. So what is the prevalence of psychological distress worldwide? Right. In receives here, the prevalence varies from 13% to around 30%. And in Malaysia, general prevalence of mental health problems is about 1 in 10 in adults and it's higher in adolescents. And half of mental health problems start by the age of 14 years old and most of them are not detected. Alright, and in Malaysia, mental health problem is the second form of second highest problem after heart problem. And you can see here, the trend is increasing by years, from 10 to 7% to 29.2% in 2015. And if you see in these figures, the prevalence of mental health problem is higher in youth age as compared to those in young adult age. Those in age 16 to 19 have higher prevalence of mental health problems as compared to those age 20 and 24. And when we see this across years, from 1996 to 2015, the prevalence is increasing in both age group. Therefore, because of the increasing prevalence of psychological distress and health impact of psychological distress, such as suicides, and it can cause academic problems and so on and so forth, this study is very important. And from the published risk factors of psychological distress, such as obesity, health risk behavior, urbanization, family problem, and all childhood adversities, we come out with this conceptual framework for this study, which are derived from socio-ecological model, from individual factors, interpersonal, community, and society factors. Therefore, it brings us to this study objective. In general, these studies aim to determine the prevalence and trend of psychological distress among youth in Peninsular Malaysia from the age of 15 to 20 years old. And specific objectives is first, to study the baseline prevalence of psychological distress among youth aged 15. Second, to examine the prevalence of psychological distress among youth aged 20. And thirdly, to investigate the changes of psychological distress from the age of 15 to 20 years old, and also study the associated factors. And last but not least, to explore the association between adverse childhood experience and also psychological distress among youth aged 20 years old. And later on, you can see why ACE is only assessed at 20 years old. Okay, some recap of this method. Professor already explained. So for this specific study, we measure psychological distress at 2 time points. First, in 2014, when the participant age is 15 years old, include youth, or another definition is adolescents. And second stage or second phase of this study is when they are at 19 to 20 years old of age. Okay, so for the first one, we obtain data from secondary My Heart data, and subsequently we follow up the student in 2020 by phone call and house visit. Alright, you can see here the flowchart of this study interview. Alright, overall, there are 1,040 participants eligible for these studies. But in the end, we have successfully interviewed only 416 through phone call interview. We obtained 22% from them. And those who did not respond to phone call interview because they already moving out, refuse to participate and all, we did house visit to 262 participant house, and only 95% participated during the house visits. So the final number of participants in this study is 416. Alright, this is some sub-data on data collection. We collect the data from January 2019 to early March 2020, and subsequently there's MCO and all. We stopped the data collection already. And then the study instrument, we use general hash questionnaire to study the dependent variable. And for independent variable, we study on individual, social demographic, and also family information. For the general hash questionnaires, we use 2 general hash questionnaires, which is GHQ28 and also GHQ12. Both derived from GHQ60, which have similar psychometric properties. We come from the study results. There are 416 participants in this study, in which majority are females from Malay ethnicity and resided in Perak. Majority of them, also about 47.8%, come from lower household income. And of parents' education, majority had parents from secondary education. Okay, then we move to our findings for first objective, which is the prevalence of psychological distress among youth aged 15 years old. Among youth aged 15 years old, there are about 15.9% of them have psychological distress, where using GHQ 28, the cutoff point is 6. Okay, and then who are they? with psychological distress. We can see the higher prevalence of psychological distress was seen among those who had high-risk behavior. You can see here. Yeah? But there's not much difference among those with gender or had normal weight. And then we can also see the highest prevalence of psychological distress were also seen among those with no formal parents with no formal education, middle household income, parents with mental health problems, ethnicity other than Malay, those from urban and also from Kuala Lumpur. And then when we did multivariate analysis, we found that 3 factors is associated with psychological distress among youth age 15, which is first, ever use alcohol. They have higher odds of psychological distress by 5.8. Secondly, family factors, which are those had parents or mother with primary or secondary education had higher prevalence of psychological distress and with odds 3 to 4. And then those who resided in urban had 3 times higher odds of psychological distress. And then as for comparison, we know that alcohol use, studies show that early onset of binge drinking is also associated with later alcohol abuse and also dependence. And increase in alcohol consumption were also noted to disturb brain neurotransmitter. And for maternal education, studies show that mothers with higher education had better mental health problems in the children. But most studies related to close parent or parent-child relationship, because some other studies where the parents or mother are housewife, the children and parents had better relationship and had better mental health outcome. And meanwhile, for urban, most studies show that higher rates of psychological distress and behavioral problems are also seen among those who reside in urban area. And the factors is because of increased stress, poverty, violence, and also reduced support, and also high expectation for those who reside in urban area. And for second objective is to study the prevalence of psychological distress among youth aged 20 years old. This study found an increasing prevalence from the age of 15, where about 34.6% of them had psychological distress. And then, similarly, here we can see that those who had psychological distress, a higher prevalence is seen among those who had high-risk behavior, ever smoke and ever use alcohol, who had past history of psychological distress at the age of 15 years old, who at this point of study were studying, and also who had parental mental health problems, and those other than Malay ethnicity. Again, similar in findings with 15 years old, those who with higher prevalence of mental health distress was seen among those who reside in urban, and also Selangor and KL, and both is highly urbanized area. So when we did multivariate analysis, we found 3 also factors are related or associated with psychological distress among youth age 20. First is study status, where we found that students at tertiary education had 8 times higher odds of having psychological distress as compared to students who work or are employed during the data collection. Secondly, those who had parent mental health problem or parents had mental health problem had 22% higher odds of having psychological distress. And thirdly, those who reside in Selangor have higher odds also having psychological distress. Alright. And this among the studies why such findings is found in our studies. And thirdly, this study also analysed adverse childhood experience among those at age 20 during follow-up analysis, because we use ACE IQ questionnaire from WHO, and this questionnaire has been validated in Malaysia among adults. Why we assess at age 20? Because this question is to be asked among those who age 20 because it's past childhood experience. And this study, we found that 63% of our study participants had at least 1 ACE, and about 10% or 1 in 10 had 4 or more ACE. And among the most frequently reported ACE are first, emotional abuse, parental separation, divorce or death, violence toward household members, bullying, and also community violence. And the higher prevalence of ACE was seen among male, those who reside in urban, Selangor, who smoke and also who consume alcohol. Alright, and then multivariate analysis to see association between ACE and also psychological distress, we found that those who had 4 or more ACE had higher odds of having psychological distress. And when we look ACE by category, those who have been bullied, have a history of sexual abuse, or living with parent mental health problems had higher odds of having psychological distress. Okay, then we move to our longitudinal analysis, where if the studies found that the prevalence of psychological distress is increased from the age of 15 to 20 years old by 15% to 34%. It's almost similar to Malaysian study where we found that the prevalence is higher among those young adults as compared to age of 16 to 19 years old. Okay, when we did GE analysis, this is the findings show a significant association longitudinally with psychological distress from the age of 15 to 20 years old. First is alcohol consumption, where it's increased the odds of having psychological by 10. And then no formal education in parents. Thirdly, parental divorce, parental mental health problem, and also other Indian and others ethnicity. So this summary of these study findings where at age of 15, the 3 factors were identified to increase the risk of psychological distress, such as alcohol use, maternal education, and urban residence. While at age of 20 years old, the study status, having past history of adverse childhood experience, having parental mental health problem, and those who reside in Selangor, which is also urban, have higher risk of psychological distress. And when we did GEE, there are 3 factors were significantly associated with psychological distress, which is alcohol use, maternal education, parental mental health, parental divorce, and also ethnicity. Therefore, as for conclusion, first, we need to promote awareness on first about mental health, how to take care of mental health, especially among youth, as they progress from adolescent to young adult during the youth age. And then we need to do more screening and encourage them to screen themselves. If they have any emotional disturbance, have in blue moods, they have to come forward and screen themselves, because when we did, because in PKD, I found that most when we Turun University, we did ENCD or did health assessment among the students. Most of them never never go to see counselors, but they have higher score on mental health problem, especially depression and stress. Okay, and then last but not least, we have to increase collaboration with other agencies. We need to engage more with the Ministry of Education, with the universities, because these are where the students are. And then we also need to engage with with the PBT or local governments, because we need to cater those who are outside the system, outside schools, outside universities, those in the community as well. Because youth is not only those who study in universities, who work, but also those who self-employed and all, because we have much influencer right now because they are self-employed. With that, I think that's it. Thank you.
Thank you very much, Dr. Noraini, for sharing those interesting findings. Okay, so now we have our last presenter for this session, Dr. Vinura Venugopal. Dr. Vinura is also a DRPH candidate from our department. She's also from the Ministry of Health Malaysia. Currently, she's working at the Pejabat Kesihatan Titiwangsa, Kuala Lumpur, an advocate for change in adolescent health. She will present her study on physical activity and its relationship with academic achievement among Malaysian adolescents. Please welcome Dr. Vinura.
Okay, thank you very much, Prof. Nick. Good morning, everybody. I'm Binura, representing on physical activity and its relationship with national-based examinations. Allow me to just remove my mask. Okay. Okay. So, before we go on, I think I also have to set a timer, right? Because I think we're having some time constraints. Okay. So, before I go on, let me talk about adolescents. Who are adolescents? So adolescents are basically anybody from the age of 10 to 19 years old. So globally, there are about 1.3 billion people, about 17% of our world population who are adolescents. And in Malaysia, there are about 5.5 million people. Okay. Okay, so sorry, I'll start again, okay? So, adolescents basically are people aged 10 to 19 years old, and they make up about 17% of our global population. So when looking at local context in Malaysia, they make about 5.5 million people. So it's about 17% of our 17 to 18% of our population as well. So ladies and gentlemen, why invest in adolescents? Because they will give us triple dividend of benefits. So investing in adolescents now, basically, we are creating healthy adolescents now, healthy future adults, and healthy future generations. So that is what I mean by triple dividend of benefits. Now, talking about physical activity, what is physical activity? Physical activity, as defined by WHO, is any bodily movement that requires energy expenditure and is performed by skeletal muscles. So, recommendation for adolescents is about 60 minutes of moderate to vigorous physical activity daily, and to include activities like muscle and bone strengthening exercises at least 3 times a week. So physical activity, as we all are aware, ladies and gentlemen, it has multiple benefits, and regular physical activity has been proven to help and prevent and also to manage non-communicable diseases. So let's look at physical activity globally. According to WHO, 81% of our school-going adolescents from the age of 11 to 17 years old are not active enough. And adolescent girls were less active than adolescent boys. How about Malaysia? In our local context, 55% of Malaysian students are physically inactive. These are primary and secondary school students, as depicted in NHMS 2017. And only 37.3% of our Malaysian secondary school students are physically active. In another study done in Malaysia in 2017, only 19.8% of these adolescents are physically active for a total of 60 minutes per day, 5 times a week. And also in Malaysia, we see the similar scenario where adolescent boys are more active than girls. So ladies and gentlemen, people who are insufficiently active have an increased risk, about 20 to 30% increased risk of death compared to people who are sufficiently active. And physical inactivity causes an increase in NCDs. It is also the 4th leading risk factor for global mortality. So prevalence of overweight and obesity is rising rapidly around the world, which leads to increase in NCDs along with high treatment costs. Let's look at NHMS 2015. Prevalence of obesity among those less than 18 was 11.9%. That was in 2015, which subsequently increased to 14.8%. This data, which I'm going to talk about right now, was recently published in 2022 in a study looking at economic impact of overweight and obesity. So childhood and adolescent male overweight and obesity in 2019 in Malaysia, ladies and gentlemen, was 38.6%. And if we do not do anything about it, it's projected to increase to 95% in 2060. As for female childhood and adolescent overweight and obesity, 30.1% in 2019, and if we do not intervene, 92.2% by 2016. Now, talking about NCD burden, I'm sure other speakers have also mentioned this, but I would like to emphasize this. NCD burden in Malaysia, 1 in 5 of us actually have diabetes, 3 in 10 of us actually have hypertension, 4 in 10 dyslipidemia. In 2016, it was estimated that 74% of our deaths were NCD related, ladies and gentlemen. And our economic impact, let's talk about overweight obesity. If we do nothing, by 2060, 3.98% of our GDP, projected GDP, we will be spending 3.98% of projected GDP because of overweight and obesity. So, actually, most of our premature deaths from NCDs are largely preventable by adopting a healthy lifestyle, a good diet, not smoking, not taking alcohol. So, in Malaysia, there were many programs done by Ministry of Health and also Ministry of Education. But despite all these programs, physical inactivity is still high. One of the programs in our Malaysian context would be One Child, One Sport. Despite having all this, we still have high rates of physical activity among our adolescents. So this actually intrigued me to look into physical activity more. And WHO, and also to look at an intervention that is school-based, because WHO has also been recommending school-based interventions in creating a healthy environment at schools. Okay, so this is a first longitudinal research study regarding physical activity and national-based examinations in a Malaysian setting involving a large sample size among our adolescents. So my objectives are to determine the relationship of physical activity and national-based examinations among Malaysian adolescents. I did two-phase study, a multi-method study. Phase 1 is a quantitative study and phase 2 is a qualitative study. Phase 1 basically to determine the relationship between socio-demographic factors, physical activity, other factors like dietary factors with the national-based examination. And phase 2 to describe the perceived barriers to physical activity among adolescents, explore the perception of teachers in regards to implementation of a physical activity program that is conducted simultaneously throughout school for all students, and most importantly to identify characteristics of a physical activity program that is feasible and sustainable in daily practices. Okay, so this is my conceptual framework. My quantitative study started off with time point 1 and time point 2. My baseline was in 2014 when the students were in Form 3, and the time point 2 was in 2016 when the students were in Form 5. Okay, so now basically we initially, as mentioned by Prof. Hazrin Even, we had a lot of students, 1361 students. But after excluding students who did not return, in my study, data from 584 students were subsequently analyzed. Okay, my dependent variable was actually a composite score. I took 4 subjects, Bahasa Malaysia, Bahasa English, Bahasa English, is English lah kan? Okay, history and also mathematics. What I did was, from the grades, I recoded it to numerical values and then subjects that matched equally in the sense that 584 students in PT3 took these subjects and 584 in SPM took these subjects. Those subjects that had a complete number of students with all subjects, those subjects were chosen. Okay. I also wanted to include science. However, in science, PT3 584 took, but in SPM only 200 took. So that was not one of the subjects I could include in my composite score. And thus, only 4 subjects were chosen. So mean of these 4 subjects were then calculated and then were rescaled to 100 to form a composite score. Okay, my phase 2 was a qualitative phase, and it involved in-depth interviews, about 30 minutes, with teachers and administrative staff from 15 rural and urban public secondary schools that took part in a previous My Heart study as well. Okay, now we shall go on to results from our quantitative phase, which is our phase 1. So majority of our students were, of course, females, and then they were Malays, majority of our students. Majority of our students came from monthly household income of less than 1,500, and parents' highest education, majority of them at least had secondary school education. When it came to characteristics of participants from 2014 and 2016, when you look at BMI actually increased throughout the year from 2014 and 2016. When you look at waist to hip ratio, that also increased from 2014 to 2016. Protein intake, those with adequate protein intake actually decreased over the years. Now we look at physical activities caused by socio-demographic characteristic over time, gender, locality, household income, maternal education in 2014, as well as paternal education in 2016 were associated with physical activity. And in physical activities caused over time, when we look, physical activity score over time, when we look, majority of our students belonged in a physical activity level, poor physical activity level. And when you look at the physical activity scores over time, there's no significant difference whether in 2014 or 2016. Now coming to demographic characteristics and results over the years, all the socio-demographic factors were significantly associated with the composite score, which is our national-based examination results for both 2014 and 2016. And when looking at physical activity results over the years, there was significant difference in the physical activity scores in 2014 with our results. And lastly, when looking at all other factors, those with a normal waist circumference in 2016 performed better in school compared to those with an abnormal waist circumference. As for the other factors, waist to height ratio. Those with normal waist to height ratio performed better. Those with normal waist to hip ratio even performed better in 2014. And in both years, those with adequate protein intake actually performed better in school. Looking at factors associated with better results in 2014, it was noted that those who were physically active had scored at least 15 points higher than those who were not physically active. Females did better. Those who had adequate protein intake did better. And those who belonged in a monthly household income more than 3,000 ringgit performed better, fared better. Now talking about 2016, factors that were involved were waist to hip ratio. Those with normal waist to hip ratio, those with females, and also those from monthly household income, higher monthly household income, about 5,000, they performed better. Using GE, this is my final analysis. Those with a normal body fat percentage, those with mothers having higher education, and females also perform better, and also as mentioned earlier, those who came from a monthly household income of above 3,000 performed better. Okay, now going on to a qualitative study. I actually interviewed 43 participants, but I had to remove 12 because these 12 were unable to provide proper information despite probing. So this is actually the socio-demographic characteristics of the study participants. A majority were females, Malay ethnicity, and when you talk about their working experience, all of them, all 31 of these teachers and administrative staff had at least a year experience of working in the school and a basic degree in education. Okay, these are the themes that I came up with from my qualitative analysis: barriers, perception, characteristics, and enablers. So barriers, of course, many of the teachers mentioned students' attitudes. Nowadays, I think the main thing, all these adolescents are hooked on are gadgets. So many of these teachers mentioned the students' attitude themselves, lack of awareness, they're hooked on the gadget, maybe lack self-esteem, and maybe because of some self-esteem issues, they're not keen to perform any physical activity at school. And number two, which was mentioned by many of our teachers, academic priority and time constraint. Many of our teachers mentioned that the main thing, or the most important thing for all schools is academic achievement. So majority of the time, or sometimes they will just skip classes or skip PE lessons in order to catch up with the syllabus. Sports facilities and equipment constraints. Many teachers, even in urban settings, mention that they do not have enough of sports facilities and sports equipment, and the sports facilities were not upgraded. For example, the field itself has a lot of holes, rains and becomes muddy. Students see this problem, they're not keen because their clothes will be dirty. We piled in sand in holes, but recurring problem. How do you expect the students to use this? Okay, lacking parents or involvement or support. Parents nowadays encourage students to be active physically. Do not encourage them to be active physically, Academic achievement is more important. Now, in talking about perception, is willingness, benefit all the teachers and academic staff. They believe that physical activity is important and it has many benefits. However, many said when you were willing as well to participate and to have a physical activity, standardized physical activity in secondary schools. However, they mentioned it should not add additional burden to them. Okay, and the type of activity chosen was something like Zumba, 5 to 10 minutes early in the morning before classes every single day, something like Zumba and so on. What is needed for them, the enablers they mentioned, it has to be made a policy. More research should be done to show there is evidence that physical activity actually can improve academic achievement, and then maybe they might follow suit. They also mentioned that they would like to be involved, the teachers would like to be involved in any policy made, any program made regarding this implementation of physical activity throughout schools. This is so because they say every time higher level authorities, they make all the rules, but they do not know what's happening on the ground. Okay, these are my strengths and limitations of my study. Okay, in conclusion, my impact of my research, it recognizes physical inactivity as a public health concern. With my studies, results from my study, I hope it increases awareness among students, parents, educators, and policymakers. And it helps in creating a healthy environment in school by increasing awareness, target groups that are less physically active, overweight, obese, those in the rural settings. And also a discussion regarding implementation of school-based intervention with the Ministry of Education. My recommendation, of course, we must start with ourselves. Increase awareness among students, parents, teachers, strengthen school help programs. And with the many programs that we have, I think I mentioned by all other speakers, make sure that we just have one program, one objective, and everybody works together and not in silo. Interagency collaboration is very important. And lastly, implementation of a national school-based standardized physical active program should be done, but there also should be proper monitoring and evaluation of programs. Thank you.
Thank you very much, Dr. Vinura, for sharing with us about your study. I feel that these are very important results which I think should be able to strengthen our current policies and also strategies. Okay, so since we are really running out of time, we have to skip the Q&A session. However, I would like to invite the participants to, if you have any questions or any comments, you can actually email Prof. Hazrin and also his team members. Okay, so thank you very much to all the speakers, Prof. Hazrin, Dr. Niti, Dr. Fathullah, Dr. Nuraini, and Dr. Vinura for addressing this interesting topic on adolescent health using findings from my HEART's adolescent cohort study. So in conclusion, there are three key messages from this session. Health problems in adolescence may persist into adulthood and have lifelong consequences. So cohort studies like my HEART's had substantially contributed to our understanding of the risk and protective factors of adolescent physical and mental health. And this has influenced the development of policies and interventions in our country. So before we close the session, please don't forget to join other carnival sessions as in the program. And for your information, the next in line is Paradigm Shift in Mental Health Care. And also all of you are invited to go to Centrepoint to visit the booths. Thank you very much, everyone, for attending this session and for your active participation, and have a great week ahead. And also, before we end, I would like to invite speakers to come forward for a group photo. Thank you very much, everyone. Have a good day. And please give a round of applause to all the speakers.
A very good morning, everyone, and Salam Sejahtera. Welcome to the Faculty of Medicine Research Carnival 2022. My name is Dr. Donny Adams. I'm from the Faculty of Education, University Malaya, and it's an absolute pleasure to be alongside all of you for our presentation today. Allow me to welcome our VIPs for the session, or shall I say the presenters for the session. Okay, and we have the first presentation by Dr. Zuraida Ahmad Sabki and her team of her team members. We also have Associate Professor Dr. Rusdi bin Abdul Rashid. We also have Associate Professor Dr. Ann Yi Hui An, and we have Dr. Benedict Francis. And our final presentation, we have Dr. Lim Po Kuen. And most importantly, I would also like to welcome all fellow Faculty of Medicine colleagues, our industry partners, our community representatives, our fellow postgraduate students, undergraduate students, and also ladies and gentlemen who are here with us this morning. So this session this morning is going to be on paradigm shift in mental care, and we will have a total of 5 presentations. And what's going to happen is as the presentations go along, and we are going to keep the Q&A at the end. So I will encourage all of you, if you do have questions for our presenters, please do note down the questions, and we will welcome questions and answer sessions at the end of all the presentations. Right? So without further ado, let me introduce the first speaker for our presentation this morning. So the first session is going to be on the title In Sync with Mental Health, Wellness from Medical Students' Perspective. And this presentation will be presented by Dr. Zuraida Ahmad Sabski, who is a senior lecturer and a psychiatrist in the Department of Psychological Medicine at the University of Malaya. And she's also the coordinator for Students' Wellness Program and has introduced psychological first aid as a tool to empower the students in mental health care. Now, with Dr. Zuraida today, also Ms. Ruvam, anak perempuan Balasubramania, Mr. Muhammad Kamal bin Muhammad Tahir, and Leon Guanjin, who are all 4th-year medical students. They are the wellness warriors with deep interest in mental health advocacy and awareness. So without further ado, please join me in welcoming Dr. Zuraida and team.
Sorry. Okay, thank you, Dr. Donny Adam, for a kind introduction. Sorry for the technical glitch. I was told to present for 20 minutes, now left with just 15 minutes, I think. But we'll try. We'll try our best. We're psychiatrists. We know how to handle difficult situations. Okay, Assalamualaikum and a very good morning to everyone. The title for today is Integration of Soul, Youth and Creativity or in Sync with Mental Health. And today I have the privilege of having my three medical students able to present their brief research on wellness from the medical students' perspectives. So there are four of us altogether, Ruben, Muhammad Kamal, and Leon. And briefly, our topic would be 5 main topics. We will make it very short. The first 2 topics will be covered by me, and the rest will be by my wellness warriors, call them. Okay, mental health issues among medical students. So
for the last decades, there have been many research that has been done, conducted by, globally, looking at the mental health issues among medical students, especially anxiety, depression, and even now burnout. So globally, anxiety and depression are two major mental health issues among medical students, in which anxiety was found to be like in 1 in every 3 students. Yeah. So I have the privilege of presenting the study done by Dr. Benedict. He's here today, one of our psychiatrists. And he did a study in 2019 among 622 medical students in the Faculty of Medicine, looking for the religious coping, religiosity, depression, and anxiety. And as you can see here, the trend of anxiety increased with the year of study and peak at year 3. So what we can learn here basically is that the first 3 years is very crucial, and this is where the curriculum in the Faculty of Medicine needs to look into this, looking at various methods how we can actually overcome this among our students. And of course, with COVID-19, it makes things even more difficult, especially for the academic staff, students alike. And in one of the studies done around 47 countries, found that about 11% of the students during the COVID-19 pandemic suffered from severe depression and having suicidal ideation. But unfortunately, as always, even in this setting, majority of them do not seek help. Yeah, only 15% of them actually look for help. And again, this is as a result of stigma. Yeah, and why we need to start our intervention at a very early age or stage of the medical student's life is because when they proceed to do the postgraduate program, again, study shows that if they during the foundation period of their medical school already suffering from mental illness, and it was not being managed appropriately, they may in the future during their postgraduate phase will be having to struggle with mental health issues. And Vanderbilt University School of Medicine has actually initiated a very good model that has been used in most of the medical schools in the United States, including Stanford College of Medicine, in which they aim to counteract the pervasive culture of intense academic pressure by just empowering the medical students. And as you can see here in the curriculum, it's actually there's a paper that has been published, and it was initiated in 2005 by 2 medical students with their deputy dean of undergraduates, and they eventually managed to actually create a very concise program and managed to get the faculty to actually incorporate wellness in the curriculum during the first year right up to the 4th years. And the focus are mainly on the 5 main domains of the wellness: mentoring, mind, social, body, and community wellness that was actually run by the medical students under the guidance of the faculty. And for us, we have the privilege of also in my department of psychological medicine, under our head of department, Professor Hatim Sulaiman, we managed to work with the medical students, with the faculty, and on the 31st October 2019, about 3 years ago, during one of the important meetings with the Deputy Dean and the representatives of the students, mental health issue was brought up, and it was in the form where they're actually pleading for help, that something needs to be done in terms of the mental health of the medical students. And a few of the medical students, like Lee Jun Chiat, who's now in final year medical students, actually initiated a Peers for Peers project. And subsequently, Gan Ziyan, who's already a doctor now, and Tan Chi Yang in the medical final year medical students, they were the president and vice president of the Medical Student Society during that time, actually propose a student-led psychological first aid. And eventually, during the peak of the COVID-19, we managed to actually initiated our first ever student wellness program conducted by Department of Psychological Medicine, Medical Student Society, and also Faculty of Medicine. And of course, in early this year, January, we conducted, after hiatus of 1 year due to COVID-19, we managed to have a second student wellness program with the support from the Deputy Dean of Student Affairs and the Department of Surgical Medicine, and of course from our wellness warriors, Mr. Kamal, Leon, and Ms. Rubem, who helped out to get as many students to join from not just from the medical students, but also from the nursing science and also the biomedical science. And therefore, I would like to humbly invite 3 of our wellness warriors to present their findings on the research that they actually conducted within 6 weeks. And don't expect so many of publications. We only would like to highlight what are the important points that the students would like the faculty members to actually look into it. Thank you.
Okay. Good morning to everyone present here today and to those who are watching online. So my name is Ruvem and I will be taking you through the slides of wellness assessment among medical students here in the Faculty of Medicine, University Malaya. So as highlighted by Dr. Zuraida in our previous slides, mental illness among medical students is on the rise. Therefore, there is a growing demand to integrate mental health and wellness in our medical school curriculum. If we were to look in our medical school, we will realize that there are some approaches that has already been put in place in order to reduce stress among medical students. For example, emphasis is given on practicing self-care and also mindfulness. Even our exams are graded as pass or fail instead of a score, which can overcome intense competition among peers. But the problem is that we do not fully understand what our medical students need in terms of wellness and how do they see wellness and mental health care. So to answer that question, we conducted a wellness needs assessment among our medical students from stage 1 up to stage 3.3 via an online Google form last year between October to November, and we managed to get about 171 respondents. So the questionnaire that we designed were based off a study that was done in Florida on the assessment of student perspective on improving wellness in medical school. So our wellness needs assessment was assessed using a 3-point Likert scale as well as 2 open-ended questions which allow the respondents to give more than one answers regarding recommendation to improve our wellness. So out of the 171 respondents, majority of them are from preclinical students. And most of them are those who stay in our residential college. About 50.3% of them made up both the B40 and also the M40 categories. When assessing the physical wellness, we found out that about 34.5% of our respondents were in the range of overweight and obese category of BMI. And a small proportion of them actually admitted to be smoking and drinking alcohol. And we also have about 8.8% of our respondents who have some sort of medical illness. So this is a glimpse of what our questionnaire looked like. So we assessed wellness based on the 7 domain of wellness by WHO, which is the intellectual or cognitive domain, physical domain, emotional domain, spiritual domain, career domain, social domain, and environment domain. So this is what our students said. So basically, the ones in pink are those who agreed with this statement, and the yellows are those who are neutral or are unsure, and green are those who disagreed with the statement. So I would like to draw your attention to statement number 9. I can find inner peace. So more than 60% of them agreed with this statement, which is great. But what is concerning is that more than 20% of them are unsure. So either they are unsure what inner peace actually means, or that they do not want to admit that they cannot find inner peace. So more than 10% of them disagreed with this statement, meaning that they actually admitted that they could not find inner peace. So similarly, in statement number 13, I am able to set boundaries. 60% of them said yes, but then we have the other 40% of them who are unsure or disagreeing. And if you look at statement number 15, I am eating a balanced diet. Half of them said yes, and half of them are unsure or disagreeing. So this actually reflects our data that I showed earlier, where about 34% of our students are in the overweight or obese category because they are not sure whether what they're eating is healthy and good for them. So then raise the question why? What is preventing our medical students from attaining wellness? So majority of them, 70% of them, said that lacks of break in between blocks, postings, and exams is the reason why. And this is especially true in preclinical years where our new block starts right before the day of RSA. Before our exam, we have a new block just before the exam. And about 60% of them think that long and hectic classes per day makes them feel too tired to do anything after that, especially exercising. And 60% of them think that there's too much to cope and they feel overwhelmed. So other factors that were highlighted during our survey were things like competitive environment, too much emphasis given on examination, and unclear scope of curriculum. So then we asked our medical students, what do you want to see? What changes do you want to see happening in our medical school? And the majority of them said that they would like or they would suggest to have some days off after examination. So having few days off after exam allow the students to relax, to rest, to sleep, and to come back fresh for the next posting or for the next exam. More than 40% of them suggested that lectures should be limited in the morning so that they are not too drained and can focus on taking care of themselves and exercising in the evening. So about 40% of them suggested that students should be allowed to take MC for mental health issues. So I think students are allowed to take MC for mental health issues, but most of them are not aware of this fact. And even if they are worried of being labeled by their peers or by the lecturers. So this is a problem of stigmatization, and they are worried that taking leave for mental health issues can jeopardize their career in the future. More than 30% of them, so if you look at bar number 4, 5, 6, these are suggestions for the administration as well as for lecturer misconduct. So more than 30% of them would like to suggest that the admin in charge of curriculum should be more open to listen to suggestions from medical students. And they also suggested that lecturers should be prohibited to make threats of consequences of failure, meaning that they're trying to say lecturers shouldn't use such term like if you do not behave a certain way, I'm going to fail you or you're going to fail the exam, because it increased the anxiety levels in medical students. And they also suggested to have a platform where they can report lecturers' misconduct anonymously. So to me, I think this highlights that there's room for us to make improvement in our medical school to provide a more happy and safe environment, learning conducive environment for our medical students. And finally, but not the least, more than 20% of them would suggest to have a wellness element integrated into our curriculum. So with that, I would like to call upon my colleague Kamal to take you through our student wellness program.
Right, thank you, Rubam. So, hello, good morning, everyone. My name is Kamal. So today I will be talking about the study that we conduct, psychological first aid, knowledge and practice among participants of the Student Wellness Program in the year 2020. So this is actually the first ever Student Wellness Program that we conducted in the year 2020. So, without further ado, let's just recap what is actually PFA. So the three main principles of PFA includes look, listen, and link. And a major proportion of the students are able to understand the principles of look and listen because it's easier for them to find the friends who need help, who need a shoulder to lean on. But the problem is when they find a situation where it's very concerning, such as their peer said that they want to harm themselves or even become suicidal, they do not know how and who is the appropriate person to link, to find. So the psychological first aid is very important for us to teach the students so that in the end of the day, they know who to refer to. Also in the PFA, we teach the responders on how to debrief themselves as an act of self-care, which is also part of the domains of wellness. Now, if you look at the next picture here, This is actually the schedule of the Student Wellness Program that we had in the year 2020. So, a brief introduction about the study. We actually did a descriptive qualitative case study among the participants who actually joined the Student Wellness Program. So we dispersed a Google form asking them feedbacks about their experiences on their level of knowledge on PFA and also how they applied this among their friends and also colleagues. So the results. So this is just the summary of the socio-demographic profile that we have. This study encompasses students from various stages of studies from year 1 to year 5 for the 2020 and 2021 session. But what I want to highlight to everyone here is that if you look at the bar chart that we can see here, the most concerning color, the orange color, means that the responder says that the participant says no to the questions that we ask. What are the questions that we ask? This is actually questions regarding to the responses on experience with PFA. When we ask the students who participates, have they ever initiated any PFA to their colleagues? Are they confident enough to apply PFA? And have they been personally approached by the colleagues to get PFA? Majority of them said no. The issue is why such thing happens. Although they have attended the Student Wellness Program where they were taught on how to give PFA towards their colleagues, they still cannot apply it in real life. So, after analyzing the feedbacks, we come up with two main important themes, which is PFA responder and also PFA recipient. So, when we ask them why do you find it is difficult to give and provide PFA? So first theme, we see that there's an adequate training received from the first Student Wellness Program on PFA. Next is fear of making mistakes in conducting PFA. But this is the most important part, which is the students are unsure how to react if the PFA recipient becomes suicidal. This again highlights the importance of why we need to educate the students and to teach them how to provide a proper PFA. Because imagine if your colleagues come to you and say they are suicidal or they want to do self-harm behavior, most of the students become anxious, they do not know how to react and whom to refer to. We also have the second theme where we look at the PFA recipient. Upon asking the students, they say that many of their friends were not even aware that there are such thing of PFA responder roles in this faculty. And they also think that their colleagues are not willing to share due to confidentiality issues, which is understandable. So, this is the result that we see for the knowledge part. Most of them attain a good level of knowledge even after a while having attended the Student Wellness Program. So we can see the blue bar chart showing us that their level of knowledge based on the correct answers that they answer to the questions are good. So these are some suggestions on PFA and Student Wellness Program from our side. So we suggested that we need to include PFA in the curriculum in view of teaching students on how to do self-care and how to help their colleagues to attend wellness. Okay, and the next one is the faculty needs to conduct PFA-like training again to emphasize on how we can cultivate the culture of wellness among our students. We also would like to suggest a website for student wellness programs promotion and also awareness. And last but not least, I think this is also very important for us, is to create a wellness tracking apps for students. Imagine that students having application to track their wellness and to have links, appropriate links on whom and how for them, how can they link their peers who need professional help in the future. So with that, I would like to end my part and I would like to call my colleagues to present his part. Thank you very much.
Hi, good morning everyone. My name is Leon. I'm a fourth year medical student. So yesterday was actually World Mental Health Day on 10th of October, and this year theme by WHO is actually to make mental health and well-being a global priority. So before we talk about mental health, let's talk about health first. So actually, the WHO defines health as a state of complete physical, mental, and social well-being, and not just by merely the absence of disease and infirmity. So what we mean by mental health? So the mental health actually means that we can holistically endorse one's ability to recognize own vulnerabilities and also own potentials, and we can actually respond rather than react to all this problem in our life. And we have the ability to cope and adapt to changes and challenges towards the day-to-day stresses. Okay, and attaining and maintaining the equilibriums of the emotional, cognitive, behavioral, and spiritual states, which should lead to resilience. And this requires basic knowledge and skills that require one's emotion and maintains healthcare. And this is what you try to promote among the medical students. Okay, so next I'm going to talk about our student wellness program. Okay, so as what my mentor mentioned just now, we will follow the Vanderbilt Medical Medical School Student Wellness Program models, where we actually have 5 domains, which include mentoring, community, body, mind, and social. But first, we will focus on 3 domains first, which is the mind, body, and mentoring. So for our faculty, we would like to focus on 3 core principles, which include mentoring and advising, where we advocate an adversary relationship between juniors and senior students and faculty and academic staff. Next, we also encourage our faculty to have a personal and professional growth, where faculty develops exposure to students for the actual life as a doctor during preclinicals, which allow positive or negative feedbacks among medical students. And this advocates student leadership to conduct and allows their creativities in addressing challenges through mind and body coherence. Okay, so to make sure our program is long-lasting and sustainable, we also work hand-in-hand with other stakeholders, like the Deputy Dean of Student Affairs, Prof. Shariza, to oversee the activities and the progress on the University Malaya Student Wellness Program. Other than that, we also work with Department of Psychological Medicine to provide access and link to mental health expert and support when student needs. Okay. Next, we also work with the Center of Counseling and Disability Empowerment, UM, to provide platform for all students to express their creativity through art therapy, mindfulness, and good therapy. So other than that, this center also provide counseling service for our students as well. And last but not least, we also work with the Bagian However Plaza to promote accessibility towards the social supports in terms of the financial, medication expenses, and accommodation. Okay, so this is a future direction for our student wellness program. So we'd like to make this program accessible for all students, including those for medical degree, nursing science, and also biomedical science. So we'll work hand in hand with Malaysia Psychiatric Association, where the Malaysia Psychiatric Association will have a student wellness chapter under the Early Career Psychiatry chapter, and students can actively participate as a subcommittee members involving in poster presentations and also committee service. And any activities we need funds. So we also have support from the Pfizer Educational Fund through the Malaysia Psychiatric Association. And last, we also have worked with the UM Sustainable Development Center to provide opportunity for our students to join the activities. So lastly, I will end our presentation with these quotes. No matter what you are physically, male or female, strong or weak, sick or healthy, everything is not as important as what you have in the heart. If you have the soul of a warrior, you are a warrior. All those other things are just the glasses of the lamp, while you are the light shining inside. Thank you.
Okay, thank you very much, Dr. Zuraida and a team of student researchers. I think they have gave a very compelling insight about the concerns of students' mental well-being, and most importantly, they have also provided solutions for it. And I think that what is quite interesting about this presentation is that it was presented by the students themselves. So the concerns and the suggestions are from the students and presented by the students. So a very compelling presentation, and thank you very much to the Wellness Warriors and Dr. Zuraida. and we hope for more of the same in the future. Okay, so let me introduce the next session. The next presenter will be presenting on Empower B40 Community Program, Empowerment of Marginalized B40 Drug Users with Job Placement and Supported Employment. And this session will be presented by Dr. Rusdi, who is currently an associate professor and clinical psychiatrist at the University of Malaya and the University Malaya Medical Center, respectively. So he is also now the director of UMCAS, the University Malaya Center of Addiction. And Dr. Rusdi has also won numerous awards such as the Anugerah Cemerlang University Malaya for Community Engagement in 2017. And he is also leading several research projects such as the LRGS and also the Research University Network grants. Okay, so without further ado, let us welcome Dr. Rusdi.
Thank you, Dr. Doni, for very nice introduction of myself. So today I'm going to talk about the MRAM project, or Malaysian Research University Network, that I got it way back in year 2019, talking about empowerment of marginalized B40. Before I start, I would like to maybe asking the audience, how many of you know any drug users in your family? Can you raise your hand here? Drug users, what I mean is substance users. Yeah, they chronically use illicit substance. Any of you? Or none of you have family members with drug users? Means you are a very good family. Okay, what am I going to talk today? Because this marginalized society, or focusing more on mentally ill patients with substance use, or what we call dual diagnosis group. Yeah. So actually, this project is still going on. Used to be called as Perkemas B40 in the past when I received the MRAN grant from the UMCare. Now we actually continue the project. We name it Empower B40. M actually means for marginalized society. M means also for Malaya University. M also means for helping or empower this community so that they can actually go on with their life. Okay, drug issue has become a major problem in our country. Since many years ago, we still cannot address the drug issues, not only in our country but in the world. Addiction now is defined as a chronic relapsing brain disease. It's considered as a medical illness. It's no more moral issues. It's already proven it's actually a disease. It's a medical disease. Okay, drug policy in Malaysia. We know that Dangerous Drug Act 1952, who actually possess any of these illicit substances that include opioid, cannabis, or even amphetamine type stimulants, they can be subjected to criminal act and sentence ranging from fine and also death by hanging. Although recently the government said death by hanging will be abolished, but it still can be done. Yeah. And Drug Rehabilitation Act 1983, if you caught positive urine, you can also go for compulsory drug rehabilitation in Pusat Serenti, at least for 3 years. And we also know other acts as well, as Poison Act, which is comprise new psychoactive substance, including ketum or metrogenous spinosa. And we know in our country, we have implemented what we call National Harm Reduction Program since year 2005 that include methadone maintenance therapy and also destination program. And why I want to highlight about this marginalized B40, because they are very related to what we call chronic unemployment. Yeah, and as a result of our drug policy of this country for the last 30 years, we have created what we call toxic society. So those who are actually been using drugs, they've been labeled as if they get caught, they've been labeled as convict or criminals, and because of this, they are having difficulty, diverted from mainstream of employment system, and actually the opportunity to get job is actually very much harder as compared to those people who are not having any criminals file. So at present, most prisons in Malaysia are overcrowding with widespread infectious disease like TB, hepatitis B and C, sexual transmitted disease, HIV, and also recently we also know that COVID-19 is also spread in the prison as well. So almost 70% of prison inmates actually going into the prison because of drug-related crime. They either use drug or they sell drug or both. Secara kecil-kecilan. And similarly, high rate of relapse after they release from rehab center. I was told that 75% of them relapse just 1 month after they release from the Serenity Center. So now we are already in the era of endemic for COVID-19. But I think everybody is still having some problems with regards to increasing numbers of new cases of mental health problems and also relapse case of drug use during pandemic COVID-19 last time. We also heard about increasing prevalence of alcohol use, motor vehicle accident as a result of drunk, and also due to substance-related problem. And in UMMC, we observe a threefold increased number of cases. And as your friend mentioned just now, my friend mentioned just now, we have this PFA for frontliners and also for UMMC staff as well. And this unemployment, salary cut, and marital issues are the main stressors for majority of patients who came into our services. And this marginalized B40 is the most affected and need specific help for continuation of their life. And this project is actually to prepare the society, the community itself for what we call decriminalization model as the way forward. Just to highlight recent newspaper cutting that mentioned prison overcrowding during our COVID-19 last time, and the spread of this uncontrolled, not only among the prisoners but even among the warden. So MRAN, Malaysian Research University Network, and Perkemas B40 or Empower B40 is a project, community project, grant under the what we call UMCare, been actually started in year 2019, extended into what we call Perkemas B40 or Program Pemerkasaan dan Rawatan Ketagihan bagi Masyarakat B40 Terpinggir. It's actually a collaboration in between Center for Addiction Science, Akademi Pengajian Islam Universiti Melaya, Pusat Asasi Sains Universiti Melaya, Advanced Manufacturing and Material Processing under Engineering, and also an NGO, what we call Sinar Kasih Kuala Lumpur. So UMCAS as a backbone for providing methadone maintenance therapy treatment and also job placement with supported employment to stabilize drug addiction and specific psychosocial intervention plus psychospiritual treatment as well, given by the APIM. And we also manufacture automated methadone dispensing machine, which is in collaboration with the AMP that suited the National Methadone Maintenance Therapy Program with central database system monitoring. And in this project, we focusing more on agricultural project involving growing this what we call pisang berangan culture. We also grow MG2 pineapple, catfish rearing, and also tilapia, and also rearing ayam kampung as a main product, supported by PASUM, or Pusat Asasi Sains, And we empower the NGO Sinar Kasih Kuala Lumpur and other NGO that also includes Insaf Muni and also Pengasih to also get involved in this project. So actually, when I preparing this slide, we at the process of proposing or propose the program. But now the program is already running in Biotech Lab in Glamilemi, Glamilemi Jelbu. We actually rebrand the program with the new name, what we call Empower B40 program. So the rationale of this project is to support the government mission to reduce rate of recidivism in prison, to support the community program and give back to society spirits. And the main objective is to provide job and also supported employment for this marginalized group, to improve the functioning and the quality of life, and to reintegrate them early into the community, and to empower them for readiness toward the decriminalization of the drug use in Malaysia in future, inshallah. So this methodology of the program. We already done with 1 acre of land in Gombak, where we see the retention rate in treatment for those drug users involved in the program. They actually retain almost 100%. Means after 2 years they've been on program, none of them actually run away from the program. They actually stay with us so that we can actually continue giving job for them, and at the same time giving all this psychosocial input. As you can see here, CAS, Appium, AMP, PASUM, and even UMMC. We have the methadone clinic. We are working together in actually helping these people so that they can actually be function in the community. Okay. However, there is a missing links. So we need to engage other agencies, particularly National Anti-Drug Agency, as well as the Prisons Department in Malaysia. So actually, we are already in discussion with them. Inshallah, probably another month or 2 months, we will actually start this project in Jelebu, in Glamilemi Biotech Lab We were actually been given about 10 acres of land to start with this project. Inshallah, if we success, Datuk VC, Professor Hamdi, will probably also give us another 100 acres of land, inshallah. We need to stabilize them before the enrollment into the program, where we actually send them for methadone program. We give them methadone therapy, and this time the methadone therapy is actually being helped by the methadone dispensing machine with automated database system, so that we can actually monitor them better. In the past, we used to see patients take methadone. Sometimes they do the doctor shopping. They take from one clinic, they go to another clinic, they miss it, and they die because of the complication of overdose of methadone. We hope with this machine, we can monitor them and we can prevent diversion of methadone and also death. So medical treatment is provided by the CAS and also UMMC. Psychosocial being provided by the Appium, and technical aspect, know-how for agriculture and also farming is actually helped by the PASUM and also AMP. With this project, we integrate the drug users into the society while they are receiving treatment, and we actually use the existing facilities in Glamilemi Biotech Lab in Jelebu, and the volunteers. The program is a volunteer-based approach from the participants. So we engage not only from the methadone clinic nearby, but also we engage the patient from the prisons, Jelebu, as well as the cure and care service center or Puspen Jelebu as well. So we hope with this project, we can actually go beyond 10 acres, and we really hope if this project success, we can probably replace the rehab center or Serenti in Malaysia. Now the government spend almost 500 million per year for 30 rehab center in Malaysia, but 1 month after they release, after they completed 2 years, almost 75% go back to drug again, and they go back into prison, and this cycle actually never finish. So we hope with this project, we can actually help the government not to spend 500 million per year, but we can actually probably give back to the government later on, another 500 million per year, inshallah. Yeah. Okay, this is some pictures. This is Biotech Research Center, Gramilemi Jelebu, where got almost 150 acres of land, which is underutilized at this moment. It's a very huge facilities. This is the land that they promised to give to us. Now we already going in. We actually developed a cabin, and I actually wanted to invite those researchers here who are willing to join this project, and also the students. You can do some research work there with us. With that, thank you very much for your attention.
Thank you very much, Associate Professor Dr. Rusdi bin Abdul Rashid, for the presentation on Empower B40 Community Program. And I think what we gathered very interestingly about this program is that it caters specifically for the Empower community, M standing for marginalized and M standing for University Malaya as well, M being Malaya. So we wish Associate Professor Dr. Rusdi all the best in the expansion of your research program. And also we would like to thank you for inviting the fellow researchers and students in this room to join you in the expansion of the project. So without further ado, let us move on to the next session. So the next session will be on tobacco control innovation. And this is specifically through a mobile app called Gumpak, right? Gumpak. Okay, sorry. Gumpak. All right, and this will be presented by Dr. Ann, and allow me to introduce her. Dr. Ann is an associate professor and clinical psychiatrist at the University of Malaya and the University Malaya Medical Center, respectively. She is now the coordinator for the Nicotine Addiction Research Group, UMCAS, and the secretary in the Addiction Medicine Association of Malaysia. So without further ado, let us welcome Associate Professor Dr. N to show us what is this mobile app called Gumpak. Okay, thank you.
Thank you, Dr. Oh, okay, thank you, Dr. Doni, for the kind introductions. And today, I want to share with you our journeys. That's how we developed these apps, tobacco control innovations, through a mobile app. It's called Gumpak. Later, I'll tell you why is it called Gumpak. So my introduction, my whole presentation includes introductions, meta-analysis of the developing these smoking cessation apps, personality theories with Gumpak and Gumpak 1. As we all know that Malaysia, in terms of smoking prevalence, we have a goal. We call it End Games for Tobacco. So by 2025, which is 2 years from now, we anticipate that smoking prevalence were down to 15%. And by 2045, we should be less than 5%. However, WHO just gave a statement that basically slapped us with the reality. It said that with the current efforts in the tobacco control, if it's all maintaining in all countries, that means that we have a tobacco tax. We're not allowed. We have tobacco free policies in certain states and certain area. We are still doing that. Our rate was only going to be declined about 20.9% by 2025. So it will never happen for 15%. So that if we're still doing what we are doing now, this goal was just a dream. And we know that this government has spent lots of money to treat for the major illnesses caused by the smoking. And the cost of treatment to cure or treat the 3 chronic diseases, namely lung cancer, ischemic heart disease, and chronic lung diseases, it was already 2.92 billion. That is the 2004 data. So now definitely is higher. And 2019's NHMS actually come out with that statement, say that our health is our responsibility. So there are some things that we can do to actually combat all these chronic diseases. So that includes control blood pressures, eating healthy diet, maintain a healthy weight, exercise regularly, and the most important one is stop smoking. I always tell my medical students, if you are in medical or surgical wards, if the consultant asks you what is the risk factors for the heart disease, what is the risk factors for poor healings or whatever sort of, just tell them smoking. You will never wrong. Yeah. So, and now we have currently have a smoking cessation assistant that including medications, services, quick lines, cessations websites, e-cigarettes, pamphlets, and so on and so forth. So, as I say just now, if we still continue to do whatever that we're doing now, we will never achieve our goal. So we don't want to let our goal become our dream. Therefore, that time in 2015, when the smartphones has become very popular, we actually aim on that. We see that is the opportunities. In 2015, we found that there is already 400 smoking cessation acts to help people to quit smoking in the markets in the US, UK, and Australia. Okay. As a researcher, we always wanted to ask, yes, it is popular, but does it work or not? Hence, we did a meta-analysis to try to look at all these smoking cessation apps in the market, whether they are reliable, accountable, and whether they working, their efficacy. So what we did was we did a meta-analysis, a systematic literature reviews, and found to try to determine the efficacy of smoking cessation apps that regarding the abstinence rates within less than 3 months and more than 3 months. And we searched it from the 2010 to 2020. And after the screenings and all the eligibilities, at the end, 16 studies was eligible to our meta-analysis because we only want the randomized control trial. Just skip this. Okay, so pool participants, right? We have a sample size is 7,998 participants. To our disappointment, you see all these smoking cessation apps, generally their abstinence rates at 4 weeks is always about 25%. Hardly go beyond that. And when the times go by, it drops. By 12 weeks, it will drop to half, like 17 to 15%. By 24 weeks, it dropped to 7-digit number. So it means 7.3 or digit numbers. And that goes to most of the smoking cessation apps that are currently available. only for this one, which is by the Masakis et al., what they have is, what is the difference from their smoking cessation apps is, right, they actually have this mobile exhaled carbon dioxides, right? So it's like a biofeedback little tool that can let the smokers to self-monitor their smoking status. So that once the abstinence rate is up to 63.9%. However, you also have to see that the control also quite high, 50.5. Yeah. Okay. So overall, yes, smoking cessation apps are working. However, there's still a huge room for improvement. Why do we think that most of the smoking cessation apps are not efficacy? One of the main reasons was actually not all the smokers were engaged with the currently existing smoking cessation apps. Currently, there is not a single smoking cessation app that was suitable for all smokers who have different characters, personalities, and preference. Therefore, smokers were not fully engaged with apps features, resulting in the low quit smoking rate. One statement for short, there's no one shoe size to fit for all. Well, we are up to this bottleneck. Yeah, and we do not want to develop another smoking cessation apps that's going to give us these smoking cessation rates of 20% that what the existing smoking cessation apps available. So we need to think of something else. What is the something else that will be different from existing smoking cessation apps that could actually help the smokers to quit smoking? And we kind to see this, then I come across this group of researchers from China by Su et al. What they find out that these mobile apps users, they also have different personality, and that different personality actually influence them how they download the apps and what apps they download. So for instance, that they say that the participants who's much more let's say belong to neuroticism, they tend to download the mobile apps of these shopping apps because they are more impulsive. They're always anxious. So they want to shop to make themselves happy. Yep. So this is a big 5 personality traits that used in their research. As we say that there's 5 domains. It's openness, conscientiousness, extraversions, agreeableness, and neuroticism. Bear in mind that no one have just one domain. Everyone we have all the domain. It's just that probably some of the domain we are much more dominant. Then come to the questions. Do smokers are all the same? Do they actually also have different personality? Which the answer is yes. This is this meta-analysis that I did together with my medical students, and is recently published in this ISI's journal. We found that smokers who are much more to be neuroticism, they have much more harder times to actually to quit smoking. And of course, they also have extraversions and agreeableness personality traits. In other words, yes, in our eyes, or for the clinicians, smokers are all the smokers. They are all the same. But actually, they are not. Even the smokers itself, they also have their own personality, and that also determines how they wanted to use the apps, and that also determines that how they want to deal with their smoking. We developed this Gempa and utilize the big 5 personality trait, and it's specifically tailor to our population based on our research findings. So gempak means get every smoker participate and quit. We do not want that only 20% of the smokers that use a smoking cessation apps and quit. So this is our insight. So we divided into 4 domains of these smoking cessation strategies. It's a calculation, social support, mindfulness, and the informations and tips to motivate smokers to quit smoking. Later on, we also, this is another our data is intentional to quit amongst Malaysia's adult smokers findings from the 2020's ITC's Malaysia survey. What we found out that only 18.9% of the smokers in these studies using smoking cessation apps to quit smoking. However, if they use these smoking cessation apps, their quit intentions within 6 months were much higher than people who use the e-cigarettes to quit, or they use these current smoking cessation services. And one of the reasons we can think of is language barrier, because most of these smoking cessation apps available now is all in English and hardly in the Bahasa Melayu. So that is why. That is why our gempak, we actually have 2 languages, Malay language and English language. And gempak also has a nearest tracking smoking cessation clinics available, which is at the left side here. And we're also working with this Bamford Scientific's iQuit smokerizers, which is little device that we showed it there that provides carbon monoxide breath test for the smokers. So if they're smoking, when they blow a breath in this little device, it can actually connect it to the smartphone, and it can detect that what's the level of their carbon monoxide. And it will show them directly. It's like a biofeedback. Yeah. So it will show them that because smokers, they always think that there's okay with them, there's nothing wrong with them, and they don't feel anything, they feel okay. But this device will tell them that no, it's not okay. Your lung system have higher levels of these carbon monoxides, which not supposed to be there. Yeah, and the higher level it goes, and this device will start to have a beeping sounds. So when it comes to 12, it will beep, 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 and 20, beep, 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 and then until like a straight beep sound. So that will make them to realize that they need to do something for their behavior. So we start to build the prototype. We have a focus group discussions. So participants will download the gempak apps from the Google stores and install the apps before starting the focus group sessions. And we will ask them to give us the feedback. That time, because it's during the MCO, so the sessions was conducted using the Google Meet. This is one of the sessions. We have 5 participants. As you can see, even we have 5 participants, so it's they all have their own preference. See, participant 1, he like smoking diary. Participant 2 like the remainders. 4 like find the clinics. 3 like the mindfulness. So despite we only got 5 participants, they already show their preference, and properly is also that is linked with their personality as well. Okay. So we probably skip that. So this is a mindful information tips and all that. Yeah. So we have these gempak 1.0 when we want to evaluate. We have this pre-test and post-test. We are still doing the research. That's why currently we had 37 participants that has completed the pre-test and the post-test. They are aged in between 21 to 35 and all males. Number of smokings is more than 6 cigarettes and above. Numbers of cigarette intake per day is again is like 6 to 10. We are in the middle of applying intellectual property IP, so I can't show you the whole results, but I can show you one. Like for example, after mapping these personalities and among the smokers, we found that the personality that dominant in the openness, they actually prefer that smokers can share their progress on quitting smoking on the Facebook or Instagram. These are the people that want to show people, they want to make friends, they want to show people what is their improvements and what is their progress. So they will actually show people that can show with the Instagrams and to get these social supports in the Instagrams or this Facebook. As you can see, this is one character. This is one personality, whereby could be a very competitive personality, because what they like the most is the top 10 warriors. In our apps, we have these top 10 warriors who can actually abstinence from smoking the longest time. So every day they have a list there. And this group of people, smokers, they actually like this one a lot. So I think that is a much more competitive personality. They want to compare and they don't want to lose. So we evaluate the efficacies. What we found that number of cigarettes intake decreased after using a Gempak 1.0. And our FTNDs, which is Frankenstein's nicotine dependent scales, also range from very high to very low. We found that 70% of them feel motivated to quit smoking after using Gempak for the first time. 65.6% of them successfully reduced their cigarette intakes. And around 12.5% quit smoking after using Gempak within more than 1 month. You can actually find our Gempaks in the Google store. You just type Gempak, it should come out, which is the first one. And we have a user feedback. Bear in mind, I did not pay them to say that. They are all users. So they say easy to use, easy to understand, and bagus untuk yang baru slow nak stop smoking and all that kind of things. Yep. We are still doing the research and doing the participant recruitment. So if you have any families or your saudara maras or your friends are keen to quit smoking, please give them this QR. So what is our next step? Our next step is actually we want to uplift our Gempak 1.0 to 2.0. So we have a new design, and we're going to carry out the randomized control trial. This project has won 2 silver awards from 2 different nationals innovations competitions. And lastly, I would like to thank that University Malaysia give us a grant to actually do this, and my Gempak team. Thank you.
Thank you very much, Associate Professor Dr. N, for that very interesting presentation on Gempak. So Gempak stands for Get Every Smokers Participate and Quit. Yeah, so you're encouraged to share this Gempak app with your friends and the community, and that more people are aware about this tobacco control innovation app. Okay, let's move on to our next presentation. Our next presentation will be by Dr. Benedict. And Dr. Benedict is going to talk about esketamine, the paradigm shift in treatment-resistant depression and suicidal behavior. Before that, please allow me to introduce Dr. Benedict. He is a psychiatrist, researcher, and lecturer based in the Department of Psychiatry, Faculty of Medicine. So Dr. Benedict's expertise is in the field of old age psychiatry, treatment-resistant depression, and functional recovery in schizophrenia. So without further ado, let us welcome Dr. Benedict.
Okay, thank you very much, Dr. Donny, for the kind introduction, and also to the other panels of speakers who have preceded me. So I'd like to share with you all today on the role of esketamine, which is a new, exciting, novel treatment in the field of treatment-resistant depression and also suicidal behavior. So we are quite privileged to be in the era whereby there are a lot of treatment modalities that we can use for patients who are depressed, moving from the classical antidepressants, which were first found in the early 90s. Now we've come all the way to esketamine, so I will share with you all today on esketamine, what research has been done thus far, and our involvement with this very interesting compound. Right, so earlier on, Prof. Rusdi asked you all, if you have any family members who have been using drugs, but I'm quite sure that all of us here have a family member, or at least we know someone who's close to us who has suffered from depression, because together with the pandemic, this is another parallel pandemic, which the global prevalence has increased in the past few years. You can see here it's 4.4% in 2015, but now I'm sure it has almost doubled. It was more than 300 million people in 2015, but again now, 2022, I'm sure it has probably reached even 1 billion people. We don't have the latest data yet. And regionally, more than 20 million people in our region suffer from this debilitating illness. Closer to home, in 2019, the National Health Morbidity Survey found that the rates of mental illness here in Malaysia is 1 in 3. That's quite staggering. It's almost 30% of Malaysians suffer from a form of mental illness. A majority of them suffering from depression. We have some Malaysian data on the epidemiology of major depressive disorders. It's about 8 to 12%. So that's the data that we have. So again, quite staggering numbers. Now these are the phases of treatment. Just to summarize to you all, the goal of treatment is of course to get patients into remission, but we don't only want them to have remission of their illness, but to enter into what we know as functional recovery. And the goal of treatment really is this. This is the holy grail of treatment. So back in the day, we used to think that people's mental illness, there's no cure. We don't really look forward to them functioning as long as they get better, they're at home, they're not causing any trouble to anyone, that's fine. But now we are in the era whereby we want them to be functional, we want them to contribute to the economy. So that's the role of treatment in these days. Now, we now know that depression is more than dysfunctional neurotransmitters. Looking at the imbalances of the monoamines in our brain, norepinephrine, dopamine, and serotonin, we know that depression is much more than that. It's now a function of inflammation in the brain. It's a function of HPA axis dysfunction, and also that of synaptic plasticity. So we now know that if we don't have enough communication between neurons in our brain, we tend to become depressed as well. And we have a lot of studies that are showing this now. Right. So we know that classical antidepressants don't really show favorable outcomes. Their rates of responses are not that robust. So classically, the rate of response is about 30%. So you get about 70% of people who don't really show optimal response to the classical antidepressants. So there is really a need to ask the question: how can we improve outcomes, and why aren't patients really responding very well to our traditional antidepressants? Now, this study trial was a large naturalistic trial that was done about 20 years ago, looking at more than 4,000 patients who were followed up over the course of 3 years. And what they found is that at every level of treatment, as treatment progressed, the rates of remission became lower and lower. So much so at level 4 of treatment, which was at a stage where a patient had already tried 3 to 4 antidepressants, the level of remission was only 13%. So this highlights the need to treat depression urgently and to start the right treatment as soon as possible, and not to wait until patients progress or rather decline down to a level where they don't really show any meaningful response to the antidepressant. Now, the concept of treatment resistance can be a bit confusing. We don't really have consensus, but what we take now is that non-response or partial response to at least two antidepressant treatment, and this antidepressant has to be given in an adequate period of time, so at least 6 to 8 weeks for each antidepressant. So if they're showing non-response, partial response, is when we use the term treatment resistance. And you'll be surprised that the rates of treatment resistance is growing now. We are finding more and more patients in our practice not seeming to respond to our usual antidepressant, and a lot of them are not very keen for ECT as well. They find ECT to be very invasive and quite barbaric, so they are not very open to it. So we are at a dilemma. So how do we treat these patients? Okay, that's fine. So there is a need for a different approach to our patients with depression. So moving from the classical monoamine hypothesis, which was developed more than 30 years ago, focusing on those three things I just mentioned to you, dopamine, norepinephrine, and serotonin, there's a shift of focus to glutamate now. So we're looking at glutamate because glutamate indirectly impacts synaptic plasticity. And we find that when we get our cells and our neurons to be more plastic, to communicate more with each other, to improve this highway of information at a neuronal level, patients tend to be less depressed. Now, this is the classical theory, whereby we are increasing the level of monoamine at the presynaptic levels. Once we increase it, and we have an increased inflow of monoamines at the postsynaptic neurons, we find that downstream patients become less depressed. So now we're talking about the glutamate system. So the focus is now on glutamate. So what they found is that when we increase glutamate, patients become more excited. The neurons become more excited. It improves the signaling of BDNF. Now, BDNF is like fertilizer to the brain. It stands for brain-derived neurotrophic factor. So patients who are depressed have an acute shortage of BDNF. So with the increase of glutamate, you're going to increase the secretion of BDNF, and this gives rise to the increased synaptic density. So there is a proliferation of neurons, synapses, and this communication between that improves. The white matter integrity improves as well, and this gives rise to lesser depression. Now, what is esketamine? Esketamine is ketamine. I'm sure you've heard of ketamine. It was first licensed as a pediatric anesthetic agent. We still use it for that purpose now. But in the 90s and early 2000s, researchers began to find that esketamine actually has antidepressant properties. So in nature, esketamine exists as a racemic compound. It is a combination of S-ketamine and also R-ketamine. And when I say enantiomers, I mean that they are mirror image of each other and they can't be superimposed. Okay. So what we use now commercially and in research is known as S-ketamine, because S-ketamine is more potent than R-ketamine and has a better safety profile as well. So how does S-ketamine help to restore synaptic function? So what S-ketamine does is that it binds and antagonizes the NMDA receptor at the GABA interneuron, and this disinhibits the glutamate neuron. And we know that glutamate is excitatory. So once it's disinhibited, this causes a surge of glutamate to be produced, and this glutamate then binds to the AMPA receptors postsynaptically, causing an increase in BDNF, and this BDNF actually activates synaptic protein synthesis and increases the formation of synapses, and thus improving depression. So what we really know is that people who are depressed, they really lack the synapses. Do you want to guess how many synapses a healthy person has? So it's about 1 million. We have about 1 trillion synapses in the brain. And in people who are depressed, they found using postmortem studies and also biochemical studies on the brains that there is a huge shortage of this synapses. So esketamine really helps to fertilize the brain and making these branches of neurons more fertile in a sense. These are the few studies that I was involved in. I'm part of the Department of Psychological Medicine Clinical Trial Unit. So we were involved in both the Transform 2 and the Sustain 1 study. So the Transform 2 study was looking at the acute effects of esketamine done in patients who have treatment-resistant depression. So what we found in this study was that at day 28, patients were showing very impressive rates of remission and response. For response, we had 69.3% of patients showing response, and for remission, more than half of them. And this is very impressive data. If you were to remember the STAR-D trial that I explained to you all, which was done 20 years ago, at level 4, the rates of remission was only 13%. But these are a similar group of patients who have failed treatment of multiple antidepressants. But with esketamine, the rates of response were almost 70%. It's a very impressive data. And if you look at the NNT, number needed to treat for response was 6, and the NNT for remission was 5. Also, very, very impressive data. So do you all know the NNT for statins? I like to ask these questions. The NNT for statin is 20, or it might even be 30. So it's between 20 to 30. Whereas for esketamine is 6. Okay, this shows that antidepressants really work and it really impacts patients. Now the Sustain 1 was a long-term trial that we also conducted here. For the Malaysian arm, we found that those who were stable remitters of their illness, esketamine decrease the risk of relapse by 51%, okay, compared to placebo. And in those who are stable responders, esketamine decrease the risk of relapse by 70% compared to those who are placebo. Now it's important to realize that esketamine itself is not an antidepressant per se, but it's an adjunctive treatment. So patients are also on an oral antidepressant, but using adjunctive esketamine. This is a very interesting statistics that I would like to highlight, the likelihood to help or harm, that looks at the ratio between the NNH to the NNT. Now, esketamine, though highly efficacious, also has some problematic side effects, or side effects that can be problematic, such as dissociation and also transient increases in BP. So this statistic looks at the trade-off between benefit and also adverse effects. What they found was that given both the safety and the efficacy data, esketamine was still more likely to help than harm by 4.1 times. Okay, and this is also quite impressive data. So despite the presence of side effects, esketamine was still more likely to help compared to harm, and this was 4 times more likely to help. Okay. All right. So this is how the device looks like. It looks like your average nasal spray. If you have taken a nasal spray before, and I believe some of us in the crowd would have taken a nasal spray before. I've taken one as well, for my sinus. So we find that it has 2 green dots. The 2 green dots means that the device is full, and when the patient administers one spray, one green dot disappears, and when the patient administers two sprays, both the green dots disappears. So we get the patient to self-administer esketamine, and this is supervised by the clinician. So I get the patients to prop up at 45 degrees and to first blow their nose, okay, and then I hand them the device, okay, make sure they're in a comfortable position, and then the patient self-administers the device. So each device for both nostrils, and then when they go on to the next device, they have to wait 5 minutes in between each devices. Okay, so each patient will get up to 3 devices depending on the severity of their depression. Now, each device contains 28 milligrams of esketamine, and as I mentioned earlier, the maximum dosage is 3 sprays, 5 minutes in between the sprays. Okay. Now, there are some side effects, but thankfully the side effect profile is very transient. The first one is dissociation. Patients get an out-of-body sensation. So I've had patients who have told me that they feel like they're in a spaceship. They feel they are out of their body. They are flying. Some people find this quite nice. They like this feeling. Some people are quite scared of it. They cry sometimes, but thankfully these feelings or sensations subsides after 90 minutes of taking the spray. So within 90 minutes, patients are back to baseline. They can return to work. Actually, they are not overly sedated, and importantly, the dissociation stops. And with more treatment cycles, as you can see in the graph, the impact of dissociation or the effect of dissociation actually reduces. And esketamine also causes transient increases in blood pressure. It's about 10 to 40 mmHg increase in systolic blood pressure, but I've never seen it go more than 10 mmHg in all the years I've been using esketamine for my patients. And also this effect on blood pressure also tends to taper off as patient takes more and more esketamine. And I've also never had a patient develop treatment emergent hypertension using esketamine. This has also been shown in the clinical trials as well. So what's important to note about esketamine is that the side effects are pretty transient, short-lived, and is also quite safe to be used. Also sedation, which peaks at about 40 minutes, and by 90 minutes, the sedation comes down. So esketamine is a team effort. This is just a portion of my support staff. The other staff were not present when I took this picture. So it has to be administered as a team. This is the esketamine room that I use. So people tend to think that giving esketamine is very difficult, especially when I talk to the other doctors from other hospitals. But actually esketamine is very easy. You just need a bed, you need a blood pressure monitoring machine, and that's about it really. And it has to be supervised by a trained clinician, and patient self-administers the esketamine. So esketamine is always given DOTS therapy. We don't allow patients to take back the esketamine because of the safety monitoring that has to be done. But patients only need to be at our center for about 90 minutes, and then they can go back accompanied by a caregiver. Okay, so this is my last slide. So consider esketamine early for patients who have treatment-resistant depression and also those who are suicidal. Esketamine has also been shown to rapidly relieve suicidal ideations, and it can prevent the usage of ECT, which is not a very welcoming thought for some patients. It has an NNT of 6, which is a very, very impressive NNT, and also good safety data. Administration of esketamine must be done cautiously, and the safety domains must be monitored. Okay, and using esketamine is a team effort, and you need a space as well in your clinic. If you want to use esketamine. Okay, so I'm more than happy to collaborate with anyone who is interested in using esketamine. For the purposes of research. We do have this medication, and it'll be quite exciting, especially if the basic sciences or those from the fundamental science areas want to work on esketamine. Okay, thank you very much, and I'm more than happy to take questions later.
Okay, thank you very much, Dr. Benedict, for that very interesting presentation on esketamine. And we also thank Dr. Benedict for providing us insights about esketamine and also the effects. And most importantly, Dr. Benedict has also welcomed future research collaboration with him and his team. So, ladies and gentlemen, I actually have two news for you. One is a good news, one is a bad news. The good news is we are very much on time. The bad news is we are at the last presentation. Okay, so let me introduce the last presentation. The last presentation is on a topic of the role of technology in addressing global mental health challenges. And this will be presented by Dr. Lim Po Kuen. And Dr. Lim Po Kuen is a lecturer and psychiatrist from the Department of Psychological Medicine at the University of Malaya. So Dr. Lim received the Chevening Awards in 2021-2022 and completed her Masters in Global Mental Health from King's College London this year. So without further ado, let us welcome Dr. Lim Po Kuen.
Thank you, Dr. Doni, for the kind introduction, and good afternoon, ladies and gentlemen. So since I'm the last presenter and I know that most of you are probably hungry by now, I'll try to make this presentation as light as possible. Hopefully by the end of the presentation, half of you will still remain here with me. To start off this topic, in last year, I studied Global Mental Health Masters in King's College London and London School of Hygiene and Tropical Medicine. And it was a great opportunity to learn from experts in the field of global mental health. And today, I'm delighted to be able to share some of the knowledge gained during the course. Before I start, let me briefly mention about the World Mental Health Day 2022, which was celebrated yesterday. The theme this year is to make mental health and well-being for all a global priority. This theme is set by the World Federation for Mental Health, and we know that during the COVID-19 pandemic, it has created a global crisis for mental health. There is a rise in anxiety and depressive disorders of more than 25% during the first year of the pandemic. So even though there is an increase in the demand for psychiatric or mental health services, but the services, skills, and funding available remain far below what is needed, especially in low and middle income countries. Therefore, it is imperative that we act now to work towards a world where mental health is valued, promoted, and protected, and everyone has equal opportunity to enjoy mental health and have access to mental health care when needed. First, let me introduce what is population mental health. It is the practice of preventing mental illness, prolonging life, and promoting mental health through organized efforts and informed choices of society, organizations, public and private, communities, and individuals. So when we talk about global mental health, we zoom out, and it is the health of populations in the global context. There are many factors which contribute to mental disorders, and research has consistently showed a strong association between social disadvantage and poor mental health. Poverty, childhood adversity, violence, all these emerge as key risk factors of mental disorders, and in turn, they are associated with loss of income due to poor educational attainment and reduced employment opportunities and productivity. So all these complex multi-directional pathways can lead to a vicious cycle of disadvantage and mental disorders. And this suggests a crucial role for mental disorders in the to integrate it in transmission of the poverty. So how can this loss be measured? There is a transformative methodological breakthrough occurred in the early 1990s, where we measure the disability-adjusted life years, DALYs. This allows the comparison of the burden of mental disorders to other health conditions such as HIV, TB, to see how, by estimating their contribution to both years of life lived with disability and to premature mortality. And the global burden of disease in 2019 showed that mental disorders remain the top 10 leading cause of burden worldwide. This high burden of mental disorders and unmet needs for care constituted a global health crisis, and it leads to the emergence of global mental health. We know that since 1990s, the field of global mental health, it played a key role in the inclusion of the Sustainable Developmental Goals. And there's increased recognition that high burden of mental disorders and unmet needs for care constituted a global health crisis. So the Lancet series on global mental health, it gave rise to increased attention in reducing the treatment gap by introducing scaling up of coverage of services. This is also run concurrently by a few reform initiatives, for example, in countries like Brazil, Ghana, China, India, to promote public health approach to mental health care. However, there are many challenges that remain in global mental health. One of the challenges is inadequate investment in mental health care. The allocations of mental health care in national health budgets and investment in mental health research in health research budgets were disproportionate to the burden of mental health conditions in all countries. There are low investments, and most budgets are spent on mental hospitals instead of putting it into community-oriented or integration of mental health in the social care platforms. Because of this, it resulted in very large treatment and care gaps, and for those who receive the treatment, the quality of care received is very poor. To give an example, talking about treatment gap inequalities, we can see that in low and middle income countries, only 1 or 2 out of 10 people with a mental health problem gets a treatment. And compared to high income country, 5 or 6 out of 10 people will get a treatment. In India and China, more than 80% of people with mental or substance use disorder, they do not seek any treatment. And for example, in depression, 1 in 5 people will receive treatment in high-income country, but only 1 in 27 in low-middle-income country. One of the reasons is because of lack of resources, and WHO recommended that 1 psychiatrist is to serve 10,000 people, but in Malaysia, 1 psychiatrist is serving 100,000 people. This is similar to the ones in India. So, the Lancet has suggested 4 innovations in global health interventions, and these are task sharing or task shifting, coordination of the foundation with primary and specialist care to achieve a balanced model of care, to implement community-based intervention, and lastly, the adoption of digital platforms to facilitate the delivery of intervention across the continuum of care. What is task shifting or sharing? Task shifting or sharing means that there is a rational redistribution of tasks among mental health workforce teams, where specific tasks are moved where and when appropriate from highly qualified health workers to other health workers with fewer qualifications. We provide them with appropriate training, support, and supervision. For example, you replace doctors with nurses to deliver the intervention, replacing nurses with healthcare assistants being replaced with community health workers. And lastly, community health workers can be community leaders, teachers, parents, or peers. So instead of 1 psychiatrist ratio to 1 to 100,000 patients, we provide the service of task shifting or task sharing so that more people will be able to deliver the service in the community. But we know that using human or manpower, there are challenges. Why? Because the community health workers, they will be overloaded with other duties, and so most of them are not properly rewarded, no funding. And some of them are not adequately trained or supervised. There's also disjointed systems with poor coordination between providers and lack of political will. So this is where technology comes into play. What can technology do in task shifting? We can treat, for example, in the Gempa app, you can use the app to treat the patients, provide support to health workers who provide the intervention to other people, help to train the health workers, and to supervise the health workers providing the intervention. In short, the digital technologies for mental health, first, you can use it to educate the public and disseminate information. We can facilitate screening and diagnosis, support the treatment, support healthcare and system-level efforts, and support effective training and supervision. Sorry, the slides did not move. Okay, so the first role that I mentioned, which is in education, we can use digital technology to disseminate information through anti-stigma campaigns and using substance use prevention messaging. SMS also to promote awareness of mental health, and using social media platform to spread information and awareness. For people living with mental disorders or family caregivers, they can find support through online communities, and also to enable them to get access to important resources, coping strategies, and some of them may prefer to subscribe or register themselves on self-help programs delivered online. Second, we can facilitate screening and diagnosis using apps or SMS. And it also allows us to examine the patterns of how the users interact online to early identify them, especially those who are at risk of depression, psychosis, suicide, or those with substance abuse. Third, digital technology can be used to support treatment and care. We can use mobile and online programs for illness self-management, so we reduce the number of people who is needed to deliver the intervention. It can be used for relapse prevention, using SMS to promote medication and adherence, using apps to track and monitor symptoms, and some of them even use wearable sensors to detect the location of the patient, the time, the activity data, and it allows to send alerts to the caregivers. Overseas, which is more commonly used now because of the pandemic, there's also online video conferencing for patients. And currently in development is the gaming interface, where they allow participants to play some game, and from that you can assess the phenotypes of mental health and then provide individualized interventions for them. In a bigger level, you can support healthcare system level efforts to improve mental health and track the patients and mental health outcomes of a defined population, so you know that which populations are more vulnerable to mental health problems. And you can also provide registries to facilitate care coordination, prompt target notifications, and identify crisis situations, and so on. For supervision and training of non-specialist health workers, it can be done through digital learning and supervision platforms, which I will give an example later. So all these healthcare workers through this digital technology will have access to specialist consultation and support. A lot of time in low and middle income countries, especially those living in rural areas, it is difficult for them to get consultation all the time or meet the psychiatrists themselves. So using digital platform, it allows them to get real-time support or consultation. There's also off-site supervision that can be done, and mentoring of local health and lay providers. It builds provider capacity, and all this will reduce the burnout and turnover of health professionals. However, it does not come without any risk or harms, such as some may mention that it lowers the effectiveness of mental health care because it's not provided by mental health professionals. And social media, as we know, is also a potential risk for mental health, like cyberbullying may occur, and the development of internet gaming disorders. There's also a challenge to ensure how safe are those information online, especially when it comes to mental health problems. And ethical risks which are involved, the privacy of the patients, the data, confidentiality, and there's also potential for intrusion and coercion, and also further discrimination through tracking and monitoring. And all this will widen the inequalities in mental health care, so policies will be needed to guide safe and effective application. So I'm going to give one example that is conducted by Dr. Ricardo Araya and team, who's also my lecturer in King's College, and he's the director of the Center of Global Mental Health. This research on effect of a digital intervention on depressive symptoms in patients with comorbid hypertension or diabetes in Brazil and Peru. Their objective is to investigate how effective is digital intervention in reducing depressive symptoms in patients with diabetes and or hypertension. In the population of 1,113 women and 199 men, they recruited 880 patients randomized in 10 clusters in Brazil and 432 patients randomized in Peru. From this group of patients, one group is the digital intervention group, and the other group will receive the usual care. And from their primary outcome is to see more than 50% of reduction in patient health questionnaire 9, which is used to measure depression. through these findings, through this research, they found that those at the 3 months score, those with digital intervention in Brazil has 40.7% of them, but those who have more than 50% of reduction in PHQ-9 score who receive the usual care, there is only 28.6% of them. So you can see that in Brazil, there's a 12.1 percentage points difference amongst those who receive digital intervention and those who did not receive the digital intervention. The same goes for Peru. There's a 18.6 percentage points for those who receive digital interventions difference compared to those who receive the enhanced usual care. However, at 6 months, the effects were found to be no more significant. On a second example, also done by the Dr. Ricardo and his team, it is a pilot study of a 2-arm non-randomized control cluster trial of a psychosocial intervention to improve the late life depression in socio-economically deprived areas of São Paulo in Brazil. This is also known as the proactive. So what is proactive? They use technology to assist delivery of intervention by nurse assistants or community health workers. So this group of nurse assistants and community health workers went for a workshop training, and subsequently they used the method of behavioral activation to provide intervention to patients. But before that, all these healthcare workers or nurse assistants, they were given materials to be used in the sessions when they want to give the intervention to the patients. So with the media professional team, they've developed 23 animated short videos with three leading anime characters, and they also provide them in a tablet, the graphs with mood ratings so that they can chart the patient's mood, the patient's adherence, they can jot down the suicide risk, take note of patients' activity levels. And this will help them this will help the health professionals to monitor how the health workers and the nurse assistants deliver this intervention to the patients. There's also a checklist to ensure fidelity of this intervention, and it allows the sharing of basic information with other team members. So this study is divided into 2 phases. They have the initial phase where they conducted 3 sessions intervention for the patients, and then subsequently the patients will enter into a second phase. Those who receive low intensity will be based on PHQ score that is less than 10, and those who will receive the high intensity intervention are those who obtain a PHQ score of more than 10. They have used 3 measures, PHQ-9, EQ-5D-5L, and ICE-CAP-O. But you can see from here that all these 3 measures of the intervention group, they started with poorer results. So for example, in PHQ-9, those in the intervention group had a score of 15.5. A higher score in PHQ-9 indicates more severe depression. Those in the control group had a score of 13.9. But during the follow-up, you can see a significant reduction in the intervention group where the score of PHQ dropped to 3.8, whereas those who received the enhanced usual care, PHQ score remained about the same at 12.3. However, because this is a pilot study, so the formal comparisons are not appropriate, but the results are at least encouraging. That was the first wave of their research. The second wave of the research, they involved using WhatsApp for elderly patients who are depressed by giving them audio and image messages through WhatsApp, and it occurs, they receive the WhatsApp messages about 4 days per week for 6 weeks. The results are not published yet, but from the patient's feedback, they seem to prefer this mode of intervention. So as we know that in Brazil, being a middle-income country, in some areas, the patients they can't afford to purchase the smartphone. So what the team did was they actually purchased the smartphone and tablet for all the patients. And surprisingly, no smartphone were missing. So you can see how appreciative they are towards this digital intervention. There are pros and cons in providing digital intervention. For example, we know that Google, Facebook, WhatsApp, Instagram, all these are widely used. And even just now in the earlier presentation from the Medical Student Welfare Program, they did mention about their wish of incorporating digital technology to ease their intervention and to help with the supervision. And in low and middle income country, comparing to high income country, there are lack of health services here, and it allows more innovation, less restrictions. However, it really depends on the resources allocated. Do we have the budget to do it? And the infrastructure and digital skill formation that we have. And because of this digital intervention, the global inequities might grow larger, the digital divide. Those who have the access to internet, those who have access to smartphone or tablet may be able to receive intervention compared to those who are more poor, who are unable to have the internet services. And there will be profit-making companies who hinder the speed of transformation and piracy issues. So this is the end of my presentation today, and we know that digital technology can be a promising tool to aid in scaling up and to provide psychosocial intervention, especially when human resources are low in low and middle income country. But more research is needed to understand how far we can move forward with digital tools. Thank you.
Okay, thank you very much, Dr. Pokwen, for that very insightful presentation on digital intervention and technological initiatives. I think particularly what was useful in Dr. Pokwen's presentation earlier is she helped bring King's College London's research to University Malaya and her collaborative research with her team in King's College London. So thank you very much for that very insightful examples. So ladies and gentlemen, at this stage, we are going to move to the Q&A session. So at this stage, I would like to welcome first our speakers to come to the stage, and then we will proceed with the Q&A. So let us welcome Dr. Zuraida Ahmad Sabki, Associate Professor Dr. Rusdi, Associate Professor Dr. N, Dr. Benedict, and also Dr. Pokwen. Please have a seat at the front. Okay, so ladies and gentlemen, and I will also like to acknowledge our audiences who are also online. So if you do have any questions for those who are in the auditorium, you have 2 mic stands. Please feel free to use those mics. You can ask any questions, or you can provide any insights that you have gathered. And most importantly, also, we welcome any form of discussion that you have for any of our speaker. And especially for our audience online, if you do have a question, please feel free to participate in this Q&A. So we do have some time for Q&A. We have until 1 p.m., so there's plenty of time for Q&A. And you can see that our speakers here are all very excited and welcoming all the Q&A. So as challenging as you can, the question, the better. Just joking, yeah? All right, let's welcome Q&A. We have the first question.
Assalamualaikum and good afternoon, everyone. So thank you so much to all the speakers and the students as well. I think the talks were really amazing. I learned so much this morning. So thank you so much for sharing your insight. I have a comment and a question for Professor Raida's team. So actually, I was really very interested in your wellness program. And actually, I've been doing something similar for the biomedical science students for the last 3 years. But we've been sort of approaching it from a slightly different angle. So for example, we've been looking at it in terms of sort of trying to encourage them to adopt some goal-driven behaviors. For example, reducing use of light-emitting devices at night, because we know that blue light is harmful. At night is harmful. Blue light at night is harmful. And also making sure that they get enough sleep, making sure that they have a proper diet as well as exercise. So I wondered whether maybe we can work together moving on. I would really love to be able to roll it out amongst the medical students and seeing if whether or not that would help. So the idea is that a lot of the sort of, we go by evidence-based science. So, a lot of research has shown that, lack of sleep can also in 20 years' time cause, potentially development of neurodegenerative diseases as well as, disrupting your body clock. So if we could work together on that, I would be really delighted. Thank you.
Thank you. Thank you so much for the comments, and of course it's a privilege that I was able to work with the 3 wellness warriors. They said they approached me for without any ideas on how to actually conduct the research and the topics. So and at that time I was looking at the application of psychological first aid or PFA, in which to some they found that the terms is rather like, they know that it's physical first aid, but is there such thing called psychological first aid? And we would like to empower the students because in Faculty of Medicine, after we have conducted the programs, then we realized we have taught the nursing science and biomedical science. And we actually for now trying to get everybody on board and to train as many to be PFA responders or wellness warriors, and to, of course, if you were to get funds, I tried to apply for grant, but I didn't get, and I hope it's very sad. So hopefully, with the collaboration, we'll be able to, to work together and expand this idea. Yeah, thank you.
Okay, thank you very much, Dr. Zuraida, for that response to that question, and thank you very much for that question as well. So there's an opportunity to collaborate and expand. As what Dr. Zuraida says, there are some areas that are yet to be explored, and we welcome future collaborations. Can we move on to the next question? Okay, thank you. Okay, thank you for the question. Dr. Benedict, your response, please.
Thank you very much, David. Excellent questions. So I'll start with the first one. So the beauty of therapeutic esketamine is that it all boils down to the dosage. So what we use therapeutically is only between 0.2 to 0.4 mg per kilogram. So this really prevents it from being abused. So the potential for abuse is very low. Recreational ketamine is actually, can be up to 4,000 times more than therapeutic ketamine in terms of its dosage. So it's much, much more potent. So what we use in our clinical practice, the dosage is very, very little. So little that its potential for abuse while there and has to be monitored is actually quite low. And this has been demonstrated in their long-term clinical trials, whereby patients who dropped out from the clinical trial were not found to have drug-seeking behavior as well. So they did not crave esketamine even though they stopped taking it in the clinical trials. And in my own clinical experience, I've been using esketamine since 2016. I find that patients who stopped taking it for logistical reasons, they couldn't come for the treatment, they don't have this drug-seeking behavior and they're okay being off it. So it's not really addictive. Psilocybin, yes, it's quite exciting, but psilocybin is a bit different from. I mean, maybe not so different. It's quite similar. Both dissociative, substances, but psilocybin, I think, can be classified as a hallucinogen. So I think there is a drive in psychiatry to work more with the psychoactive substances, especially substances that can induce a dissociative state and also hallucinogens, because there's this new wave of thinking in psychiatry is that if you use substances that can induce these states in patients, it can actually facilitate recovery in depression, because these states are able to modify the patient's prior cognitive beliefs. So once they're in a dissociative state, they experience some kind of cognitive restructuring, and this helps in their recovery from their depression. So there is a new drive going towards the psychoactive agents. So and certainly in the West, they're doing a lot of research on psilocybin. Some people call it magic mushrooms and all these things. And I think Prof. Rusdi, who's a substance specialist, and also Prof. Ann would also probably can also comment on this.
Yeah, I do receive some feedback from some of my patients, especially those going into depression and also treatment-resistant depression. They've been self-medicated with mushroom, phencyclidine, and looking through their story, because it's not just one. Quite a number of patients already stated to me about the use of these hallucinogens, and they say that it's actually helping their depression as well. Maybe looking forward, we should probably have some research being done also on this substance. Similarly, like ketamine, in the past we thought that it's an illicit substance. We only think about the negative impact, consequences of using this, but who knows? It's actually a very good medicine for treatment-resistant depression. I noticed since Dr. Ben and my fellow colleague been using this esketamine, the number of numbers of ECT that we carry out, electroconvulsive therapy in our ward is actually going down significantly. So I believe whatever substance, the bottom line, if we use it in moderation, or we use it not overdose, I believe God created all these substance for the use. Similarly, like knife, if you're using knife for good purposes, it will be benefiting everybody. But if you use it for killing people, then it's no good. So the hallucinogen probably also have roles in treatment of any mental illness, including depression. Thank you.
Okay, so thank you very much, Dr. Benedict and Dr. Rusdi, for that response, and also thank you very much for that question. Do we have a third question? Okay, thank you. So looks like this session is very engaging, yeah?
Hi, I'm Atika, Committee for Research Carnival. I would like to read one question from the online platform. This question is to Prof. N. The question is, how is Gempa app going to be financially sustainable? Thank you.
Yeah.
Okay, Prof. N, your response, please.
Yes. Okay. Thanks for the questions. Yes. So for now, we're moving onwards. It's also we're trying to make these apps to be sustainable, which is now I'm actually engaging this industry and the Ministries of Health to try to see whether they will be interested in our apps, and subsequently probably will make our apps to be sustainable to be part of their services. So for example, that recently the announcements of these from Ministers of Health, YB Khairi did say that's generational end games. So we actually give our proposal that how our smoking cessation apps have a role inside in their whole proposal. So we are trying to get this to be sustainable. And second ways that we're doing, and we are still negotiating, is we are meeting up with the Benford company, the one that's have the smokalizer. So we are trying to have a deal that is whether the value of their selling their smokalizer at the lower price if you are the Gempak user. So to see whether they are interested or not. We just had the meeting last week. So the negotiations is still ongoing.
Okay, thank you very much, Prof. N. So at this juncture, we can conclude that sponsorship for the Gempak Act is most welcome, especially from the audiences. Okay, do we have a fourth question, please?
Ask another one.
All right, please.
Okay. So I was very interested to see the talk on the role of technology in mental health. And I mean, I've come across this criticism of modern technology in fact also being the cause of a lot of poor mental health and sort of this surveillance capitalism that is mining human experience and sort of encroaching on our life in these very sort of possibly harmful ways. What do you think might be the role of looking at the negative role of technology in mental health, perhaps?
Okay, we welcome Dr. Pokmen for the response.
Yeah, thank you for the question. My own opinion would be that I think we need to look at the pros and the cons, the risk and the benefits of it, because yes, what you said is partially right. There's a role of the social media or internet use that can lead to mental health disorder, but if we are using the technology in the right way, for example, in the two examples that I've given, where it's properly supervised, properly monitored, and it's used in helping to deliver intervention, helping to scale up programs. At the end of it, it may be more cost-effective compared to us using manpower and worrying about the risk of using internet or applications that will lead to mental health disorders. So yeah, so it's not something that, yes, we know that this thing has a risk, but it will not stop us from doing it, because moving forward, for this young generation, people especially, we know that internet is one of the main, it's like their life partner, they cannot just live without internet anymore. And for us to be able to spread awareness, for us to be able to deliver intervention in a more effective way, one of it is by using digital technology. Yeah.
Okay, thank you very much, Dr. Pokmen, for the response. And thank you for the question. We still do have time for some more questions. Any more questions from the audience? Or maybe our health warriors? Okay, we do have another question.
Hi, I'd just like to ask about the issue of post-trial, post-treatment availability. So I think obviously, of course, crucial in the methadone program as well, right? So we know that the sustainability of that methadone is crucial for the program. So similarly, I think we heard about the psilocybin as well. So we had the issue of, there have been an issue about post-trial access as well. So what do you see? Is there a problem with this esketamine as well? Is the dose that has been sort of cured or, recovered by the use of esketamine? Do you foresee that you have to continue giving esketamine so that they don't succumb back to the problem?
Okay, thank you for that question. Dr. Rusli or Dr. Benedict, yeah?
Okay, thanks for the question. As to how long to use esketamine, we don't have clinical trial data to support that answer. But for my personal experience, I think about 6 months is a good period to use esketamine. After 6 months, you may be able to stop it, and patients tend to continue to be well. Of course, in patients who have suicidal ideations, you only need to use esketamine for 1 month. So cost-wise, it's more affordable for them. Of course, using it in treatment-resistant depression might be more expensive for them. So we already have esketamine now. It is available commercially in and is one of the few hospitals in the country that patients have access to esketamine. It's one of the few public funded institutions that has access to esketamine. So we are quite excited to use it. And certainly from our experience, with this compound since the early 2000s really. So we have about 20 years worth of experience with esketamine. We know that it's safe and it's efficacious. And so far the long-term safety data has been quite impressive as well. So we've not had any patient who has developed treatment-emergent psychosis, treatment-emergent hypertension, for example. And also the dissociation potential for abuse with esketamine has been very, very low, because there are a lot of things which has been put in place to minimize all these potential adverse effects. For example, the clinician has to monitor every administration of esketamine for at least 90 minutes, and patient is not allowed to take home the esketamine. Sort of a lot like methadone in the earlier days. Prof. Rusty, you want to add on anything?
Esketamine is quite new. As Dr. Ben mentioned, the data is limited for long-term use. But with regard to methadone, it's already been studied and researched, I think more than 60 years ago. And if we look into our country situation with regard to methadone treatment, I believe methadone has changed the paradigm of drug addiction treatment in Malaysia. I remember 30 years ago, our 30 rehab center, Pusat Serenity in Malaysia, is full with drug addicts. If I'm not mistaken, I think more than 15,000 occupy drug rehab center in Malaysia years ago. But now, about a month ago, I met Deputy Director of ADK, Datuk Sadiq. He mentioned only 2,000 drug addicts remain in Pusat Serenity nowadays. And we have somewhere around 50,000 of methadone patients receiving treatment in methadone clinic and also hospitals. And majority of them is actually functioning in the society. But of course, they're working by themselves or working part-time. That is still a problem. That is why I come up with Empower B40 program. Because of this toxic society were not being given job. They cannot go into university, they cannot go into the government program, even private industry also don't want to take them. But I believe at the end of the story, we want them to be functioning back in the society. That is our goal. And I hope that answers your question. Thank you.
Okay, thank you very much, Dr. Rusty and Dr. Benedict. We will take one final question, and I also like to acknowledge our student researchers here, our wellness warriors. We have Mr. Kamal, Ms. Ruba, and also we have Mr. Tahe and Mr. Leon, yeah? We also have three of them. Sorry, Mr. Leon, Mr. Kamal, and Ms. Ruvam. So they are the wellness warriors of our Faculty of Medicine. So do we have any questions for our wellness warriors? No questions? Going once? Going twice? Okay, so I think we will bring a close to the Q&A session. So at this juncture, we would like to invite all our presenters to just step forward, and we would like to take a group photo with all of you. Come, our wellness warriors as well. Okay, so thank you very much to all our audiences for this afternoon, those who are in the auditorium and also those who are following us online. We also thank all our presenters as well for a very insightful presentations. We had 5 presentations altogether. And also for our audiences who are following our Research Carnival, please note that we have further programs for the today and also for the next few days. Could we flash the program? Do we have the program for this afternoon? Those from the IT department, could you flash the program? Okay, those who are online, you can follow our program as well. We'll flash it for you shortly. You'll take this. Okay, we will share the program through our social media and through the website. Do check it out. I will also invite all our audiences to check out Centerpoint. There are more booths available there. Do check out Centerpoints and you will get more information at Centerpoint. All right. So thank you very much. Thank you, everyone, and see you in our next sessions. Goodbye.
Test, check.